Good morning and welcome to the August 30th, 2023 Board of Health meeting. And we are going to go into executive session for up to 30 minutes and members will be in conference room. Thank you. All right, welcome back. Thank you for your patience, everyone. We're going to move on with the introduction of guests and staff. Mr. Iva.
Okay, so we'll start out with two staff members that we have. I'll let Sean introduce the staff member.
Yeah, good morning. We have Kate Walterstorff. She is our new environmental health program manager. And we have Nick Gully, who's our new environmental health specialist. So they both started in their role August 16th. We're excited to have them on board.
Welcome.
And then we have several guests. What's that? Oh, and then I'm sorry, we have one other one. We have Rudy. Rudy has been with the Yakima Health District, and he was helping out with COVID. Started out at the front desk, went to COVID, and then now he is been recently named our grants contract and project coordinator. So welcome to Rudy.
Welcome. All right. We are going to move into public comment.
Okay, do we want to introduce the guests or?
Yes, go ahead.
Okay.
I'm sorry.
Okay, and then we have several guests in the back. If you want to go ahead and introduce yourself. Right.
I'm Santiago Trump with the Yakima Herald.
I'm Rachel Drummond. I'm the program director for Connect, which is a Suboxone program that covers Kittitas and Yakima counties.
My name is Jillian Zuckerman. I'm the medical director for the same.
And I'm Diane Whitmire. I'm an RN care coordinator for the Yakima Connect program team.
Dan Moorbacher with Yakima Heart Safe Initiative and AED Advocates.
Darcy Roberts, community member.
Megan Tweedy, community member.
Mike Johnson, Yakima Union Gospel Mission.
Caitlin Hill, I'm the program director of the residency. I'm Cassie Lesson, the clinical director of SCP services at Triumph.
Well, welcome. So as we move into public comment, we are allowing 15 minutes, and we will give each person or group together 3 minutes to address whatever you would like. So we will start. I guess we have a group of 3 here to start. And so if you would, at this point in time, stand up so we can all hear you and see who is speaking, we'd appreciate that.
Dear members of the Yakima Health District Board of Health. Community Health of Central Washington would like to take this opportunity to commend and thank the Yakima Health District for their forward-thinking and evidence-based decision to procure vending machines to dispense naloxone in Yakima County. This move is far from radical, duplicating similar efforts in Clark, Skamania, Klickitat, Pierce, King, Chelan, Okanagan, and Grant counties. Naloxone vending machines are one of the easiest ways to get life-saving medication into the hands of people who need it. There's significant fear and misunderstanding circulating in our community right now regarding fentanyl and people who use drugs. We strongly feel it is the obligation of the medical and scientific community to reiterate some facts on naloxone and its impact in our community. Naloxone, also known by its trade name Narcan, is an opioid overdose reversal agent, which is highly effective when administered by the general public. The medication reverses 75 to 100% of opioid overdoses, though multiple doses may be required where synthetic opioids like fentanyl are the cause of the overdose. Emergency services should always be notified at the time of utilization in case additional management is needed. Due to its incredible capacity to save lives and its impressive safety profile, there have been many national, state, and grassroots efforts to expand access to naloxone. All 50 states have passed laws to expand naloxone access for the general public. In Washington state, naloxone is available from any pharmacy without a prescription by standing order. There is also a free mail order naloxone service provided by the University of Washington. Additionally, anyone may request a prescription from their provider. The FDA has recently approved it as an over-the-counter medicine this fall. You may see Narcan sitting right next to Tylenol and Tums. Unfortunately, despite these excellent efforts, naloxone is still not making it into the hands of those who need it most due to barriers like cost and transportation. It can be difficult to wrap our minds around the harm reduction goal of naloxone. Aren't we enabling drug use by lessening the negative consequence of overdose? Unfortunately, this represents a fundamental misunderstanding of addiction. To quote our diagnostic criteria for substance use disorder, affected individuals will use again and again, even when it puts them in danger. In other words, the threat of negative consequences up to and including death does not effectively deter a hijacked brain from seeking a drug. If threat of death were a viable preventative against drug use, fentanyl and other highly risky drugs simply would not exist. Multiple studies have demonstrated this concept, finding, sorry.
It's been 3 minutes.
Oh, okay.
A lot of people, but we appreciate your sharing your thoughts. Thank you very much.
Dan Morbacher with Yakima Heart Safe Initiative and AED Advocates. I'll circle back to Narcan in a moment because that is part of our mission. But we also set up public access automated external defibrillator programs. In each of the public access sites that we'll be setting up, the first 5 will be in the downtown corridor. There will be located also Narcan, and if possible, we'll have EpiPens and stop the bleed kits. These will be in lock cases that someone would call 911. 911 would give them the 4-digit code to the case. On opening that case, they would then be able to have access to that life-saving equipment. 911 would then change the code so that we're going to know when something is taken out of the case, primarily so we can replenish it. We're not trying to restrict access. We're trying to make sure that we can keep that access available. The only pushback that I'm getting at this point is, as you mentioned, the concern that aren't we promoting the use of narcotics if we provide them with an easy out. One Parks and Recreation Service specifically said, we'd like to get these people out of the parks. They do so much damage. Even if the concern is not for the individual that is going to be the end user of the Narcan, the societal damage that a death due to narcotic overdose charges, it's not the wife's fault, it's not the children's fault, and it's not our fault as taxpayers now that they're going to be on the public rolls and we're going to have to take care of them. The cost of that Narcan and saving that life is so much less expensive. Public access AEDs the same way. We'll come back to that another time when we're talking about youth athletics and the need to be able to have a defibrillator available within 3 minutes. Want to make sure you're all aware that at Eisenhower High School in May, we had a public access save where a 16-year-old was running a relay, went into cardiac arrest. CPR was started immediately, AED used within 42 seconds. When the first engine company got there, she was waving to the crowd and doing fine. She'll be back playing athletics again. Anyone that watched the Buffalo Bills play on Sunday saw Damar Hamlin, who died on national TV, playing as well. With Narcan, we've already started distributing under a grant that we have with the health department. I just placed 7 locations in the 410 corridor. Oak Creek got 12, and I'm working up 12 now. And we're probably going to be locating in businesses along North First Street and downtown Yakima next. So if any of you are aware of someone that we can assist, we also do free training in Narcan, Stop the Bleed, EpiPens, CPR, and AEDs. The only thing that we would charge for is if someone needs certification. I get charged for that, so we would charge. Please use that.
Thank you very much.
I promise a minute 30. Good morning. My name is Darcy Roberts. I am a mother who adopted a child at birth. My husband and I were there the day he was born. He was born addicted to no fault of his own and has struggled since infancy. We have tried to derail him unsuccessfully his entire life from what has seemed at times inevitable, which is his struggle with mental health and addiction. 2 years ago, when my son was 18, I arrived at his friend's home at 8 a.m. to take him to the dentist, to the scene of him on a stretcher in the front yard. 2 doses of Narcan saved his life that day. He was blue when found, and it's a miracle that he is still with us, trying to fight this disease. Today, he is 20, the caring father of a 15-month-old, and is currently in voluntary treatment. In the end, He may not beat this monster of addiction, but the availability of Narcan gives him a chance to keep trying, and us as parents, a chance to keep hoping and praying. The idea that providing Narcan is somehow encouraging drug use or that is encouraging overdose is offensive. Ask my son how horrific it was to have gone through that experience. He isn't voluntarily using with the idea that Narcan will save him. He is fighting against a disease that has taken over his life and the lives of many. Please make Narcan readily available so that people can be given the chance to live. Thank you.
Good morning. My name is Megan Tweedy. One of the challenges as a activist preventing death by fentanyl overdose is choosing which story to tell. The emotional toll 3 years later of my brother's death, coupled with the public stigma and rhetoric that at times crushes my soul. Or do I go into the data around the effectiveness of evidence-based practices like Narcan? Which story do I tell in the few minutes I have to save the most lives possible? Those of us who have lost loved ones to fentanyl desperately wish that someone had been there to breathe life, Narcan, back into their failing respiratory systems. No matter where our loved ones are on the on the spectrum of opioid use disorder, in treatment, refusing treatment, incarcerated, homeless, or wealthy, it's not our role to condemn and judge those who are stricken, sick, and struggling, just as it is not our role to decide which disease is worthy of treatment. We know drug use is complex and will always be a part of our society. Some ways of using drugs are safer than others, not fentanyl. Narcan is the intervention that can save lives. Community Narcan distribution is shown to be effective in reducing overdose deaths. Please support free access to Narcan. Instead of punishing and scorning those who are struggling, may we all use this as an opportunity to check our stigma at the door and be ready to save a life.
Thank you.
Mike Johnson, Union Gospel Mission. Just cut out a couple of minutes. Hopefully what's left is coherent. Narcan kiosks are being deployed in a growing number of municipalities. Like needle exchange programs, they can demonstrate outcomes within a narrow goal set. Our staff administer Narcan in life-saving situations multiple times a month. And yet with deep respect to friends and neighbors, it's my concerted professional opinion that automated direct dispensing of Narcan remains a well-intentioned idea that should be opposed. When the risk of behavior is perceived as decreasing, that the incidence of that behavior increases. So births from unplanned pregnancies increased rather than decreased when abortion was legalized. Cannabis use has increased. So has the prevalence of cannabis use disorder. Directly dispensing Narcan on the street will promote illicit drug use by moving the perceived danger line. That is, by increasing the amount that a person can use. It's no fun to be brought back out of an OD from Narcan, but the perception that there is a safety net there will, know this for 16 years, hundreds of people that I know. So, this will deepen a person's addiction by accelerating tolerance through heavier use. Heavier use will result in more death. What happens when somebody doesn't have the Narcan that they thought they had, or a friend's Narcan, or the friend that's on Narcan duty, the designated driver, is inspired instead to partake along with everyone else? After all, more death will spur consideration of the next harm reduction option, which will be monitored use sites. And the cycle will continue. The dysfunction of directly dispensing Narcan on the street, though, is not limited to its very real potential for having limited to potentially inverse impact on overall death. Those outside the discipline of public health also see a worsening overall problem of illicit drug use. Those of other disciplines see the supply of taxpayer-funded drug paraphernalia, for example, as sending a clear message of social tolerance. They see that our public policies have come to expect modern society just comes with a certain amount of open air public drug use interwoven with chronic homelessness. And so the narrow goal of wanting to save life is, of course, beautiful and precious and important, but making addiction less harmful makes it more sustainable. Government-funded addiction sustainability programs, coupled with changes into law enforcement to send a message of social tolerance. And so our communities get more use over time, more harm, more homelessness, more crime, more poverty, all conditions that negatively impact health. The goals of in being considered here, in attempting to find expression in programs and policies, the analysis needs to become more interdisciplinary. We simply must reckon with the broader public impact of proposed public health policies, or we risk enhancing the dynamics that drive the very harm we're seeking to reduce.
I'm sorry, but your time is up. Thank you very much.
Yeah.
Caitlin Hill with the residency program. I'll just make a brief statement. Our residents care for several patients every month in the hospital on different services, and then we get the pleasure of taking care of them in the outpatient clinics as well. And oftentimes we get a chance to take care of them because they've had access to Narcan. We should be increasing access to Narcan so that when a teenager who is trying something for the first time happens to have something that has fentanyl in it, which is becoming more and more common, that they actually have an ability to have their life saved by someone who's around them, who has access to Narcan, who has Narcan on them, so that they can have an opportunity to grow, to live kind of the life. We're here to save lives. I went into medicine to save lives. This helps us save lives.
Thank you.
That hasn't already been said, sorry.
Madam Chairperson, I would like to make a request that we extend the public comment period, given that you have two physicians, two nurses, two community members, and one of our esteemed leaders of our substance use treatment community here. I don't believe anybody on the Board of Health is necessarily an expert in addiction, and we are here to provide some expertise. And this is not something that can be addressed in a 15-minute time frame.
I appreciate your request. For the sake of respecting the time on the board, I'm going to deny that request. However, I would encourage you to submit in writing and emails all the information that you wish, and it will be submitted to all the board members.
Just make one comment. So the letter from Central Washington County Medicine Residency Program, which was read, the very first letter, was submitted to the board so they can read it in its entirety, and also be on our website so the public can read it in its entirety also.
Thank you. You're welcome. Okay. But thank you all for being here today. We do really appreciate and value the participation in conversations. All right, we're going to move on to the consent agenda. And I'll just a motion to approve all items listed below with a bullet point are considered routine by health board. That will be enacted by one motion. There will be no separate discussion of these items unless the board member requests, in which event the item will be removed from the consent agenda and considered in smaller sequence on the agenda. Does any board health member wish to remove an item from the agenda? Barbara, would you read it, please?
Yeah, July 26, 2023, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in July 2023 in the amount of $1,015,021.33.
Here I move that we approve the consent agenda as read. I'll second.
So we have a motion and a second to approve the consent agenda as read. All of those in favor, please say aye.
Aye.
Any opposed? All right, it passes. Thank you very much. We will now move into the Yakima Health District Spotlight, which is Foundational Public Health Services, and Lillian Bravo, Director of Public Partnerships.
Thank you. So I believe it was Commissioner Lindy last meeting that asked for a little bit more information on foundational public health services. So that's what we'll be talking about today in the brief presentation. So an FPHS is what we lovingly call it on the here. So on the next slide. lovingly, and you'll see why. Foundational public health services were developed and modeled after the 10 essential public health services relevant to the field of public health. But these foundational public health services were developed all with the governmental public health in mind. So as you all know, hopefully from your orientation, you remember that there's specific laws and RCWs that are in place that provide different aspects of health that need to be governed by local public health as well. So that's taken into consideration. So again, foundational public health services works to define the work that a local public health jurisdiction should be able to provide, with the intent to set some sort of standard about what types of public health services should be available across all communities in Washington state. So in the next slide, we'll see that the purpose of developing these statewide standards was essentially to come up with a number to identify the fact that there's more funding that's needed for public health. There was an analysis that was done in 2018 that I'll reference shortly, but the purpose again of developing these definitions was to be able to identify how much funding was needed to provide all these services that are considered foundational. And again, it's with that acknowledgement that public health has long been underfunded, and that additional funding is needed to make sure that we can adequately address the current issues of modern times. And again, to make sure that these services can be delivered. And in the next slide, the study that I referenced earlier was the assessment around how much money does it actually take to be able to provide foundational public health services across all communities. And for Washington state, that number was $450 million per biennium, which roughly equals to $30 per person per year. And again, that's to ensure that's $30 per person per year to ensure that these different foundational public health services are available to everyone in Washington state. And outside of those foundational public health services, so if we're talking about innovation or responding to emergent needs outside of what was already defined, additional funding is recommended or was recommended. The next slide, we'll see that thankfully the state of Washington did approve and also agree that additional funding was needed for this state public health system. So in 2019, $28 million were approved for the biennium. That roughly equals to about 6% of the original ask. And then in 2021, the state legislature again agreed that additional funding was needed for public health. And after the pandemic, 33% of the original ask was approved for a total of $147 million across the state of Washington over 2 years. And what that looks like for the Yakima Health District specifically, we'll see in the next slide, that over the last 4 years, as you can see on the next slide, the light blue funding is general public health funding. The slightly darker blue is COVID-19 funding, and the navy blue is what is FPHS funding. So you'll see over the last 4 years, it has been increasing for a portion of our budget, getting up to an estimated 30% this year. Of course, we have to keep in mind over the last 4 years, most of our funding was to help directly support the COVID-19 pandemic. And that, as you can see through that middle bar graph in the middle, has decreased over time as our services have declined related to COVID-19. But there's still additional funding that's been received. And this year we anticipate that will be about $3.3 million. Next slide. So what does that actually look like? The easiest way to tell is when you walk down our halls and you look at this chart. The orange represents the different directors at the Yakima Health District, and the yellow represents the rest of the staff that were doing the work as well. So in 2019, we had 31 full-time equivalents, and as of today, we have 49 full-time equivalents with a couple open positions. So that's the most that's the easiest way to look at some of the changes. But on the next slide, we'll see some of the other investments that were made related to essentially updating our infrastructure. So in being able to hire additional staff, we now have a new dedicated staff for things like communication. So for the first time, the Yakima Health District has someone that's dedicated full-time to respond to media inquiries, update our website, develop social media posts, respond to different needs, and also also having software available to automate some of those messaging needs that are needed as well. Another investment, of course, we just introduced Rudy this morning as our grants manager. These are positions that are needed in any organization, and especially in the public health agency that's working across partnerships, making sure that we have software that manages the different grants and their amounts when they're coming up. There's all these details that are needed to maintain the infrastructure and the integrity of a public health agency, just like any other business. And then outside of that, we also are able to have an epidemiologist for the first time, where again, as we talk about the different critical pieces of a public health agency, being able to analyze the data, collect the data, provide surveillance to the community is also pieces that we've been able to invest in. And of course, as listed, updated facilities, vehicles, and technology to support all the great work that the staff is needed, making sure that they can do the best job possible, get with the right resources. Next slide. And so again, what the FPHS was intended for was to provide additional funding to public health agencies to provide a better infrastructure. And that's what we were able to do here at the Yakima Health District. What that also means is that we're able to do expanded programming and ultimately to be able to better respond to community needs. So just this year alone, I'm sure y'all have heard we had to respond to several different environmental health issues. So with the different landfills, we were able to expand West Nile virus surveillance. We've actually been able to participate in some of the in helping communities in SELA related to the PFAS contamination, as well as being able to do more work in the lower valley around Guama. All of those initiatives have been able to take place due to the funding related to FPHS. And there's many others, but those are the ones that I'll highlight today. Next slide. And as always, we always conclude with how does this relate to our strategic goals? I do think that it's self-explanatory, but I'll go through those again. Deliver mandated service for those in the community. These are the Yakima Health District strategic goals of delivering mandated services, which are again the services that I referred to as being specific to local governmental public health, developing a network of community partners invested in improving public health, and then of course ensuring that we're increasing the effectiveness and efficiency of the district services. All of these things are what the FPHS funding are allowing us to do now and moving forward. And I will not conclude without mentioning that FPHS was developed in Washington State with through a combination of different health professionals and experts, one of those being Andre. He's on the statewide steering committee and has been a great representative for Yakima across the state as well.
Thank you. Do we have any questions for Lilia this morning?
That's a beautiful presentation.
Yeah.
Just a clarification on, so obviously our health district has changed over the last 4 years drastically, and we've seen an increase in the foundation health funding coming to the district. And I equate that to the growth that we're having and FTEs that we're able to sustain. So my question is now that we're dependent upon the foundation health board there, is that revenue, do we have to go after that every single year, or do we get that slated for a 4-year period, or like how comfortable are that we're going to continue to have that revenue source moving forward?
Yes, thank you. What it is essentially a partnership with the other 3 main foundational partners in the State Board of Health, the State Department of Health, right? So it's a 4-pronged approach with local health jurisdictions. The money comes directly from the state legislature. So whereas often we receive funding, and Kate's often talks about our consolidating contract with the State Department of Health, that money comes through the State Department of Health to us. This is money that comes directly to us from the state legislature. So it's a new relationship. You are correct that there are always concerns around continued funding. So the funding has expanded, but we are investing heavily in a bright future that's dependent on a strong budget, and this is part of it. So we spend a great deal of time ensuring that the state legislature understands how imperative this is. And so we have it at the end of the year, as an example, a time for each jurisdiction, each member of this partnership to place all their information about how they've grown, their efficiencies, their successes, and that is then shared with the state legislature. So I think it's important for us to tend our relationship with the legislature to receive the funding. It is not a guarantee, but it's very clear that there have been increased investments. The other piece to this is it's more nimble funding than we have ever received. Normally, governmental public health money is quite categorical, so you're receiving it for breast and cervical care or diabetes care or SNAP Ed, Supplementary Nutrition Assistance Program. This allows us to be more nimble and respond to the needs of the community, which we've been able to then share with the legislature exactly what we needed to be responsive to each individual community because our communities are.
Thank you.
So Andre, I have a follow-up for that. So
Yeah.
because it's not a permanent funding source, they must have a certain requirement that there's some data to be able to come back and show and demonstrate that the funds that were utilized had a positive impact. How do you measure it? So what specifically, if it isn't categorical, how do you make the decision on what to spend? How are you tracking that so that we can go back to the legislature and say with confidence that the money is actually being used wisely and efficiently and having the outcome that's desired?
Yes, well, there's consensus built into it, working within the entire system, the partners. So we're in agreement with how to move forward. There's fundamental areas which we can follow up with and share by email. There's areas where there's investments being made. Things like environmental public health, communications, disease prevention, and disease response. And also what's called life court, which is allowing people to grow up healthy and well. So all the investments in how we care for individuals within the community. So there's prevention built into that, things like child death review. So we can share that with the board. There are areas of investment that are, what Lillian responded to correctly, are foundational to the governmental work that we do. So we have to meet that criteria. We can't just build buildings as an example. It has to have a purpose built into it. So we address those issues and then we can share that with the board.
And so they're asking you to check in, I assume pretty regular, to say, in this particular category, the goal was to reduce a certain thing, and then you're tracking to show that there was a reduction.
Yes, I will be very honest. A lot of the things that we're talking about when it comes to prevention or changing communities' habits or outcomes are long-term. And that's one of the things that has been difficult, is that you have to begin this process early in order to allow for the results to show. So that's one of the other things, is it's not immediate, you know, but you are correct. Our goal is to track information and share that and do so appropriately, which we do. Thank you.
Any other questions? Right. Thank you, Ms. Brown. We appreciate that. And we will move into agency reports, starting with Executive Director from the Press.
Well, thank you. Good morning to the board and good morning to the members of the public who are here with us today. I want to be brief because we do have a large agenda and we've already taken time within executive session. I want to recognize that when we talk about foundational public health services, I do want to take a few minutes just to discuss that. When we entered into the COVID situation, we were recognizing that we would receive a lot of money for COVID related issues. But as we prepared for strategically what would happen as we transitioned out of COVID, Ryan, myself, Chase, and the executive team at the health district spent a great deal of time talking about what we would do to ensure the integrity of the process moving forward, that we had a strong budget, that we were prepared to respond to the needs of the community. Foundation Public Health Services has been pivotal to that, but it's also something that we incorporated into our work. It wasn't just a funding source for us, it was a strategic planning tool to allow us to permit a more responsive public health system. There's a tendency, I think, in government to do work only to the needs of the grant that you're responding to. That's not something that we've ever embraced here, but we certainly were able to capitalize on this large investment from the state because it allowed us to, again, be more responsive. And you've seen that with things like the PFAS issues that we're addressing, or the fact that we've had multiple fires at our solid waste facilities, or the concerns around Guama and the ability to assist with providing water to people who are affected with the the ability for an organization like ours to respond to the needs of the community is integral to what we're doing here. And I want to share with you that one of the things we are attempting to do in our negotiations with the state legislature was to ensure that each individual community could share how they needed to respond to the needs of the community. We are a specific community, we're a vibrant community, or we're also a very large community, a rural community, an agricultural community. We have different needs than other counties, and we wanted to be able to determine what our work was in our future investment in the community. So that's worked out well. But we really have been transitioning out of COVID with an investment in having staff and communications and epidemiology so that we can be responsive with data and with the needs of the community. The other thing I wanted to discuss is that we have a strong budget that we're going to be sharing with you. There have been many years in the past and many years before my time here in my role where we really did have struggling budgets. And the legislature was not investing in public health, and there were threats to cuts of 20 to 30% to our funding streams. That is not the case now. What we're going to be introducing to you is a pretty strong budget. I don't want to take away from Ryan and Chase through that process, but at least in terms of budgeting, things are on the mend, certainly. And that's helpful for us because it allows our staff to focus not on concerns around reducing staff or budget cuts, but really on just serving the community every day when we come to work. The other thing is that we're going to have some discussions around the lock zone under new business. So it's something that's going to come up in some of our presentations. So I just wanted to share my thoughts on that. And that's all for me, unless the board has questions.
Questions, Commissioner Fusco?
Okay, as Andre mentioned, we are in budget planning season. And so in front of you, you do have a list of the proposed fee schedule for 2024. So we have the adopted 2023 fees, and then we have the proposed 2024 fees. We thought we'd make it easy on you, and we haven't made any changes. The exact same fee as 2023. And so what we'll do, the next sheet, there's a budget planning schedule. We will, next week, we will notify the public in the paper on our website of a fee hearing that will take place at our next board meeting. And 2 weeks from now, we'll be meeting every year with the board chair and board vice chair. So somewhere around the Wednesday, the 13th of September, we'll be scheduling with you guys, kind of find time that we can kind of talk about budget and any concerns that we have. Yes, yeah. And then at the next board meeting, we will have a fee hearing. So if anyone has any comments in the public, they can do that. The board can adopt it with the fees, and then we'll also be introducing the proposed budget for 2024. We will also be in October, be notifying the public of a budget hearing, and on the beginning of October, and then the October meeting, we will have there'll be a budget hearing, and then they'll go for the board for approval. November, we don't have a meeting November, December at regular time because of the holidays, so we combine the two together, and then we have a meeting the first week, Wednesday of December every year. So if for some reason the budget's not approved in October, we'll have a December meeting that we can approve budget. Any questions?
I have one question just on one item, and maybe we can come back to it, and it might be related to the foundation health, but one thing that just kind of stuck out to me was the special food handlers class, and typically those are students. $800 is a lot, and especially when we're hoping to encourage young kids to go out and work, and I'm just wondering if there's an opportunity to supplement that from.
Oh, so what that is,
to be clear, it's
that's a minimum. So for us to go out and teach a class, we want 20 people, and it's $10 per person.
Okay.
Just like we here.
Oh, I know.
Yeah, we don't want to go out and teach a class.
I was about to raise my hand.
I can-
And in fact, those rates are set by the state, not
Yeah,
us.
it's $10.
So, and
Okay.
actually, in fairness, that's something that I'd like to discuss. It's something that we talked about a great deal. It would be very interesting to be able to provide that food handlers class for free and no charge, especially for people, young people who need that. People who are coming out of domestic abuse situations who require that, people who are coming out of incarceration or the drug rehabilitation system so they can gain employment. I'd love to do that, but we don't allow to do that necessarily, but it's something that we've actually talked about many years. We'd like to be able to do. We don't encourage raising fees simply because we raise fees or raise revenue, if you will, but I'd like to have that discussion with you because it's $10, but in fairness, many students don't have that, and we've spent money in our family giving money to children so that they don't have to pay $10, but it's a barrier. So thank you for bringing that up.
I could, Andre, if I could piggyback, I'm wondering if, I mean, $10 isn't a large amount, but you actually mentioned for some people it is. I'm wondering if that could either be, maybe a private, or a public portion of the budget to address that, or maybe even a public or a private fund.
Yes, it is.
Contribute to and help.
Yes, thank you, Commissioner Lindy. What we do have to be careful of is avoiding what could be considered the appearance of vehicle. So I recognize everything you're saying, and I'd like to spend some time with you. It's exciting for me because again, one of the things I love about this state, not every state has a food handler's card. A food handler's card to me is the opportunity for someone to earn a fair wage and so a living wage. And so it's exciting to me when we have people coming into the food. So I'd like to continue that.
Yeah, so the private fund might avoid that problem,
Correct.
you know.
Thank you very much.
So if anyone does have any questions in the next month on the fee schedule, feel free to get a hold of me and I can answer any questions you have.
Ryan, when was the last time we did a major update to the fees?
Across the board is 2009.
Okay.
We did do in 2015, we did add some in our drinking water program. We added some fees and increased those. But it's been a long time since we've been.
Are you able to just tell us what things potentially, so you just brought up that that's in particular something the state sets, so is there a way to at least delineate for us so that we know if there's a question about something, we can at least say, well, that's not something that we actually have control over anyway?
Yeah, another one example would be birth and death certificates. We don't set those fees. Pretty much everything else is set by the.
The food handler cards is a state, but the very last page on page 3, the vital records has an RCW reference next to it. Yeah, those are set, those particular are set by the state. Yeah.
I'd like to add something too, if I may. There are many times in fee-based work, environmental health specifically, where we spend many hours on an issue that we do not then expect the private business to pay. One, because it could be too much for them to pay. Two, because we don't want to appear to be punitive in any way, and it's complicated to keep track of that. One of the beauties of the Foundational Public Health Services work is it supports and encourages our investment in solving problems and in educating the public. So that actually allows us to focus on not raising fees or revenue through a permit or a fee. It allows us to just do good public health work. So I want to share with you that one of the areas we've heavily invested this year has been in environmental health specifically for that reason. It supports new staff, it supports people like Kate in their role, it allows us to hire new staff, and it's not dependent on expecting the public to bear the cost. They're paying for it in fairness through taxpayer dollars, but not an individual. And one of the reasons that we are committed to that is because it allows in a difficult economic environment, not raising fees.
Any other questions? All right, then we will move ahead to Mr. Porter for the financial report.
All right, good morning. The financial report starts on page 8, where you can follow along. And I'd like to start by giving an update about our audit. Our audit is finally wrapping up. We're scheduled to have our exit interviews next week, Tuesday next week, and so we're excited to do that. We experienced the single and the financial audit. They audited our financial statements and our federal awards. We were actually scheduled to have an accountability audit. However, the state auditors are they're really far behind, actually. They've been auditing a lot of COVID, a lot of municipalities that they haven't had an audit before because of, they're having an audit now because of COVID. And so they are incredibly far behind, and they requested to do a 3-year accountability audit next year. And so, we're willing to kick that can down the road and do that some other time. They weren't going to be able to start until, we were expecting them to start in September, but they want to be able to start until mid-November. And that's just a bad time for everybody around. So they requested for 3 years, and we're happy to oblige. So getting into the financial statements, for the month of July, we had an $185,000 gain with a prior period adjustment of $55,000, bringing our total excess revenue to around $1.5 million. As Andre said earlier, we have a contract with the Department of Health. We call it the CONCON, a consolidated contract. And that's set up in a fiscal period that ended in the end of June. So getting the billing and the invoicing all in goes into August. And that was the reason for the prior period adjustment. That was for our breast cancer health program, our public health emergency preparedness response, and solid waste. So for the year, our budgeted revenue for through the month of July was 5.8 million, or actually 7.1. And budget expense was 5.9, and actuals coming in at 5.6. Any questions about the summary page? Please go ahead and interrupt me if you have any questions about the financials. Moving into the income statement, not a lot to note here. Other than I just the investment income is really skyrocketing there, 678,000. That's quite a bit. Any questions on this page?
Just really quick on contracted services on the bottom there, we were budgeting for 55, we're already at 91. So 35,000 plus over budget. What's just ideally what's new with that?
You know, I'm not exactly sure for that particular one. I believe that is our Culligan water delivery. We did not budget for that at the end of last year. I'll look into those figures. a little
Actually,
bit.
it's legal.
Legal? Okay. That would make sense then.
Yep.
We should talk more about that.
He's well worth it.
He is. He is for sure.
Actually, well, our legal is up above for that, but yes. Yeah, we have our own legal line. But yeah, no, I'm thinking that is the Culligan delivery. I'll look into a little bit further into that for next period. Moving into the second page, we have about 5 months remaining of the year, and that's kind of what I'm looking at the far end of the column. We have about $4.5 million left to spend on the budget. Earlier in the year, I expressed that there may be a concern with our additional FPHS money that we would need, it might need an amendment for expensing. Right now, a little over halfway through the year, it does not look like we're gonna need that, but we're kind of close to that line. So I'm keeping an eye on that in the next remaining of the year.
Ryan might need to clarify his statement previous.
Yeah, so our attorney wants us to make sure that legal is a separate line item, so we'll look into what the contracted services.
Yeah, legal got its own- he gets his own line item, you know, he's.
Expensive, James.
Worth every penny though, right? Yeah, wait, since COVID, it has really gone up. Any questions on the income statement?
Hearing none, then we will move on to disease control, Melissa.
Oh, I'm sorry, I wasn't correct on that. I'm moving into the statements. If there's no questions, we can. Oh, I'm sorry, just about that particular page. Yes, I apologize. So for FPHS funding, we have this clay section at the top here, kind of in blue 101 through 805. That's our FPHS, and you can see that as a wide range of activities from administration to epidemiology, tuberculosis, environmental health, solid waste, chronic disease. And so that's a wide range that we're using that funding for. If there's no questions, moving into the second page of the program statement. Again, not a lot, the same trends are continuing through the year. We've seen an uptick in solid waste activity. Any questions about that? Moving into the COVID income statement, little activity happening there. Not much going on with the COVID expenses at the moment. And finally, the cash flow report, we had a slight uptick in cash for the month of July, which would be expected as we receive our flexible dollars, and we'll also see an uptick in August as we see our foundational public health funding come in in August. That concludes my report. If there is no more time. Thank you. Oh, no worries.
So we will move then to.
We have Dr.
Welcome, Dr. Edwards. So we will move to disease control, Melissa Gray.
Melissa
I'm sorry,
is
I'm
unable.
Yeah, this is Tanya Brett. I'm sorry.
Thank you for having me. I'll give a brief report on the disease control department today. I will piggyback off of Dr. Barg's presentation from last month where he did address Shigella, which we are seeing a lot of in our community right now. I ran a report this morning. Year to date, we're up to 43 cases compared to 7 in the same time period for last year.
Shigella is a GI illness that causes fever, nausea, vomiting, diarrhea, abdominal pain, cramping. Generally, people will recover just fine on their own within 3 to 10 days. Usually don't require any medical attention. So the cases that are reported to us are the people that are experiencing severe illness. They're the people that are going to the emergency department and getting tested. Of those 43 cases this year, we've had 17 hospitalizations. And like I said, those are the more severe cases. So with 43 cases reported to us, that indicates that it's fairly widespread throughout the community. Just it's something people don't see the doctor a lot for. So we have done some outreach to local urgent care clinics and also some of the shelters in the community too, to provide education regarding hygiene and proper food handling. Shigella is spread via the fecal oral route, so contaminated food products, contaminated water, and sexual contact. So that's where we are with that. We haven't seen Shigella affecting one demographic group right now in Yakima. It's pretty widespread among different groups, age groups. We've seen children, adults, male, female. So nothing really specific there, unfortunately. We haven't been able to narrow down where it came from. We just know that it's spreading.
Are we the only county experiencing this, or is it just widespread in Washington?
King County and Spokane had seen an uptick in cases. Last time I spoke with Spokane, their cases had started to drop. However, we're staying steady. We're continuing to have cases come in. King County did have an outbreak early in January, but I don't know their data as of right now. My next update would be COVID. We are up to 86 cases per 100,000 right now compared to last month. During the Board of Health meeting, we were at 15 cases per 100,000. We're seeing an increase in long-term care facilities as well. And we are also in the middle of a syphilis outbreak that has been going on since 2021. We are continuing to offer free testing for STIs. We do have a fairly large barrier right now as the first line treatment for syphilis is experiencing a shortage nationwide. And that is due to increased cases of syphilis nationwide. And my last update is one that I'm pretty excited about. We've been working on a project to reach out to our community partners, local providers and organizations. We are planning to start up a monthly meeting with these partners so that YHD can provide updates as what we are seeing as far as our statistics go, and to provide education to providers. It's also an opportunity for providers to share with us what we are seeing, because we don't get the data unless it's reported to us. We're really excited that we can take this opportunity to strengthen interprofessional relationships within our community to improve the health of our community. And that is all I have for today. Are there any questions?
Melissa is working on, or the health district is working on expanding the harm reduction program in the Lower Valley, particularly in Toppenish. Is there any updates there?
Lillian has updates
All
on
right,
that.
well, wait, thank you.
Right, too. Yeah, so though that there is movement, the team did meet with the city council in Toppenish, and so the second location is on track to start in this fall at a location in Toppenish. So we're talking to a few different locations. But as of the last update, things are moving forward, and we'll be set to announce the location and start date here in the next couple of weeks. And so with that, I know one of the pieces that was asked about was what's some of the data around the harm reduction program overall. So I can share that in more detail with I'm interested, but just some quick high level data points that were able to be collected for 2023 for the Yakima site specifically, is that there have been over 1,000 interactions with at least 414 community members that have visited the program at least once in this year alone. With that, that's been 57,000 syringes collected by our staff, almost over 1,100 naloxone kits that have been distributed. And then in terms of testing, there's been 49 syphilis and HIV tests that have been done, as well as 32 hepatitis C tests, and a total of 53 referrals. Some of those for referrals to social services and some of those to treatment services. And unfortunately, we weren't able to get the data from Comprehensive and Merit Resources, who are the ones who primarily do the case referrals for treatment itself. So the numbers are likely higher. But again, we're happy to compile this information. That's just for the last 8 months. And we have data for the previous years as well. But I did want to share that as a quick update that that data has been compiled, and we'll be using that as a template for the second side as well to make sure that we have our information and evaluation available when that opens up as well.
Thank you. I do have a question. So if it's 414 individuals and only 53 referrals, how are we not referring every person who comes?
Yeah, and that's not a complete number, as I mentioned, because this is only for accounting for YHD staff. I'm happy to provide the information from Comprehensive and Merit. And so that's a referral in terms of people that accept the referral. So of course, that's being offered to every person, but not every person will take the step to go and get go to the services itself.
Just to expand on that, the question, I assume that's a referral on site,
Yes.
right? Like that outreach worker has that conversation and then they're logging that, yes, I'm connecting them to resources. Versus every single person that visits the harm reduction site is being told of services and they may or may not choose after that fact to engage in those services.
Correct.
And we don't know that number.
Correct.
Okay.
Correct.
And so Lillian, I'll follow up to that too. When we were talking about the referrals, that we wanted to also track the outcomes if they actually showed up and if they actually were successfully entered into treatment. So you have data on that, or you can't? get that data?
Yeah, that is something that's part of who actually attended the referral appointment is available.
Well, we don't need to know who, but we just.
We'll only get
Yeah.
in terms of the number, yes.
Yes.
So that is a template that's available and it's being utilized and was developed by the team. And again, we have that for the Yakima site, and as we expand into the Lower Valley, that will be available as well.
And part of that was to work with the nation in the Lower Valley on those mental health reports. But being available to all members of the community who request them. And I just, if I may go back to what Tanya was talking to, as a nurse, she's been pivotal in this concept of working more closely with partners. But we also have something called the Provider Resources website, which we helped create years ago with funding. Originally, this started small amounts of funding from the Foundation of Public Health Services, but we partnered with Tacoma Pierce County, who had created it, and it allows us to have a template online to reach clinicians. It used to be here that if there were specific questions around protocols or directions, somebody would call us in the middle of the night. Certainly is not advisable. So what we have now is a resource website where we can share information from a public health perspective with the larger medical, which has been really great. So this is in addition to that.
Any further questions? All right, thank you, Ms. Britt. We appreciate that.
Thank you.
We move to local emergency response coordinator, Andy
One
Wilson.
question, if I could.
Go ahead, Dr. Atterbury.
Yeah, the COVID report just a minute ago, I just didn't hear. She mentioned that there was an increase or uptake in nursing facilities. Was that generically nursing facilities or was that a particular center? I was just wondering.
Long-term care facilities. I don't have the exact number of long-term care facilities, but a majority are reporting outbreak status at this point.
So not isolated to one.
No.
Got it.
Thank you. Questions? And here's your high place.
Yeah, morning. So for the month of August, we were relatively busy. Health district responded and worked on a few incidents. First one was a boil water advisory in Terrace Heights at the beginning of August. We were with Yakima County Public Services and the State Department of Health. Worked through that, and that was completed, and the boil water advisory was stopped on 17th of August.
We had the Olympic Fruit Warehouse Fire in Moxie. That was on August 11th. There was 4,000 pounds of ammonia released. They had a shelter in place. We worked with Emergency Management, Department of Ecology, and State Department of Health to work through that process. And Environmental Health Program was working with the local residents there for shallow wells for their drinking water. Let's see, we had multiple wildfire alerts. We had the big smoke. So we worked with Department of Health on that to get messaging out. We're still with ETG, we're still in ICS for that. They began work in July. They're expected to complete that work in the end of November. Right now, they're working in the highest fire activity area. So in the next 2 or 3 weeks, we should get through that process. So that's going well. And for the future, we are working with emergency management on a functional drill at the Yakima Air Terminal. And next year that'll work into a full-scale drill. Anybody have any questions?
I think you covered a wide range.
There was a lot in there. There was a lot.
There are no questions, then we'll move to D for environmental health.
Yeah. Good morning, everybody. So environmental health, we are wrapping up on our summer seasonal inspections. That includes our recreational schools, our summer camps, our summer school food programs, sanitary surveys, which is inspections of our large community water systems that we partner with the Department of Health Office of Drinking Water with. So that's setting us up nicely to head into our fall and winter seasons to wrap up our land development busy season on a strong note. And then get back working heavier in our food safety program. We do a lot of majority of our food inspections in the winter, or have opportunity to do more food inspections in the winter when the busy months down. And then we get to Kate and I will be working heavily on some of our procedure and policy development for our staff to help them be more efficient in the field. We're continuing to work fairly heavily in solid waste on the permit renewals for our 2 limited purpose landfills. We're continuing to work with those facilities and provide information and be a resource to them on how to move forward and get their permit renewal documents in order, and tracking where they're at with other requirements from other agencies that they need to meet in order to get a permit. So we're continuing to engage with those facilities regularly and extend our resources and knowledge when they need them. So that's really all the major things that are happening in environmental health. Try to stay brief, but if there's any questions.
I do actually have a question.
Yeah.
I know that there was recently a hearing that was involved for the appeals hearing for Caton. And I'm just wondering if you had a chance to look at the data that was brought forth in that hearing. Can you tell us whether or not the amount of material that was disclosed to have been dumped there, does it exceed the amount that they are actually able to have received as far as material from their land use permit?
Yes, so there is 2 permits that facility is required to have: a clean air permit and their land use permit through the county. The decision for their land use permit was approved based on the proposed 50,000 cubic yards per year that facility would receive. That same amount also is reflected in their current clean air permit that was approved in 1997. So that was one of the deciding factors on that approval. It's up to 50,000 cubic yards per year. The last 5 years in a row, they have exceeded 50,000 cubic yards. So the most recent annual report that they're required to send to Department of Ecology and us here at the Health District, which outlines the amount of waste they received in 2022's annual report. They received 462,000 cubic yards of waste.
So not a little.
Not
Okay, and they itemize certain amounts of material? I know you don't know exactly, but so for example, there was a representation that a certain portion was recyclable material. Does it talk about the types of material?
Yes, so They break it down. The annual report is solid waste received to the facility, and that's broken down between, ferrous metals, woody debris, yard waste type debris, fiberglass, different materials they're allowed to accept under their permit. It's broken down categorically there. And then there's also a section of number of recyclables removed from that waste they received, and then recyclables sent from the facility to a recycling center.
Okay.
I'm wondering, do we have any indication in terms of recyclables, whether they're able actually to recycle out of what they receive and where that's going?
The annual reports for that 5-year period, I believe they received, it totals up to between 600 and 700 cubic yards of 600 and 700,000 cubic yards of waste, if not more. I'd have to add it up again. I did the math a while ago, but they removed a little over 600 cubic yards of waste in that 5-year period for recycling.
So about
0.078%.
You're good. Sean, do you have any particular concern about any of the items that they're bringing in?
It's pretty specific what they're allowed to bring in. They do have the ability to strip down and remove hazardous materials from different vehicles like RVs, boats, and dispose of the shell of those vehicles at the landfill. We have seen times where there is an abatement truck in the waste pile abating the materials out of those vehicles. It's supposed to be done on an impermeable pad outside of the waste. Their largest waste stream, which I don't know if has continued since their permit was not renewed, but when they were permitted, the waste stream coming in from Canada was very ground up materials that if not handled properly, as we saw, can spontaneously combust if there's too much oxygen introduced to it.
What kind of materials are we talking about?
It's mostly woody debris. So without the right compaction factor, the right slope angles on the sides and the right amount of daily cover or intermittent cover, that material can decompose quickly or generate heat, and the introduction of oxygen can combust.
So you just said that one of the largest amount. So what you're saying is that based off the data that was provided, most of the materials being deposited are coming from outside of the country.
Yes.
Thank you.
And just a quick note on this annual report that is submitted to Ecology, it's self-reporting, correct?
Self-reporting.
Yeah, it's the applicant that's self-reporting. Yep.
I want to come back
It's a
to my-
requirement of the WAC, but they do self-report.
I want to come back to my question about percentage of recyclables. So it's like probably less than 1%.
It is less than 1%. That's on the annual report.
And is there any to be considered recycling facility? Is there any percentage that is that needs to be met to be a recycling facility?
It's not defined in the WACs of a percentage about what qualifies as a recycling facility. But if you look at DTG, for example, they have a permitted material recovery facility. They have a sorting line, they have a designated place, all waste goes through the sorting line, they remove recyclables. They send recyclables to the appropriate recycling center. Metals go to a metal recycler, plastics to a plastic recycler, etc. And those are reported. And I believe I would have to confirm what the percentage is on DTG's recycling rate, but it's quite high. I would say in excess of 10% of all materials going into DTG is being recycled. It may be much higher than that, but I would have to look at their annual report.
Just as a comparison.
And in that sense too, if you comparing the two, DTG is allowed to operate their recycling operation, but they still were required to cease the practice of landfilling and the actual landfill. The residuals for DTG, they are taking elsewhere.
You just mentioned, so there's a separate permit that has to be issued to actually be a licensed recycling business.
Yes, there is a permit.
So one could argue that any business could receive donations of something, and though they specify that they only want perishables, for example, just because someone drops off fresh chicken, that doesn't make them someone who deals in fresh chicken. So it's a byproduct that just happenstance. It seems like they did receive material. It was not intended to be recyclable. It just happened to have been, and so they plucked it out.
Right.
To the tune of a very small fraction over the course of time. So I think what we're driving at here is that even though they did receive recyclable material, that does not make them a recycling business.
I think that's the question, yes.
Yes, and the material recovery facility is a permitted operation through the health district. A facility could apply for an exemption for recycling, but we have not received such request.
John, just to clarify, DTG has a permit to do so. Does Caton have a permit to do so?
No. They have exclusively a limited purpose landfill solid waste permit. Did.
And of course, as we're talking about all these amounts that are being brought in, the amount that actually shouldn't be being brought in right now should be zero because their permit was not raised.
Correct.
Yes, if I may, I want to clarify, they currently do not have a permit for,
I meant did.
yes, they did not have a permit currently because they are not renewed, so they are not a solid waste facility currently. And they do not have a material recovery facility. They have-
And we did send a letter, I believe it was on July 3rd. The third day after their it was the Monday after their permit expired, we found they were operating. And we sent them a letter with our stance on they're not a recycling facility. They requested to cease operation effective immediately, and they politely declined.
Well, as a PSA to anyone listening to health board meeting, it would be great if all of the residents and anyone from Canada who wants to dump anything, if they could avoid Caton, that would be great since they are not licensed to accept your materials.
Any further comments or questions for Mr. McGee?
Just really quickly, we talked about all these items that are coming. You mentioned mostly woody debris. Was there anything else that any other materials that are coming in the budget of concern?
On a consistent basis, we have not seen a consistent stream of inappropriate waste in that facility. The times we have found inappropriate waste, such as they're allowed to collect shredded rubber. We have found tires in more of a wholesome form, which is not allowed. They have sent those tires back and had them shredded or ground up more and then disposed of in the landfill. But there's not a consistent stream of inappropriate waste coming to that landfill. Now, there is questions from the Department of Ecology about is the waste coming from Canada and appropriate waste, given it's come in a pretty ground up form. And obviously it did not handle appropriately to show that it can catch fire.
What types of products, if you were to grind them up, would be more likely to catch fire?
Woody debris. Well, woody debris that is not compacted and is allowed to decompose more rapidly and have oxygen introduced to it. So all this waste that they've accepted, if they're landfilling appropriately with the correct side slopes, the correct compaction, and they're covering the waste appropriately, it inhibits the introduction of oxygen and fire cannot happen.
And if they're accepting material in excess of the 50,000, upwards of 486,000, it seems unlikely that they would be using the appropriate slopes and backfilling. Given the fact that they're willing to so egregiously exceed the amount to which they are licensed the material, accept material.
That has been in their past inspections, that has been a cited violation, is their side slopes have been too steep.
So just to follow up, so as you mentioned, the woody debris, so I noticed you didn't just say wood per se, you said woody debris. So is this a composite material that they're grinding up that has?
It's construction demolition waste mostly. So you'll have gypsum, the paper backing for drywall. You'll have broken up, ground up wood from demolition from homes, manufactured homes. You'll have concrete, asphalt, things of that nature. I'm not sure about asphalt. I'd have to double check on that with the concrete.
Thanks.
Any other questions? And thank you.
Just one
Right.
question. Do you have any data from the past year or couple of years as to how much international woody debris they've been taking in?
That exact number would be tougher to track. We would have to potentially collect all the trucking logs from the facility itself. Which we can request. But if you look at the past annual reports, it jumps by more than 200,000 cubic yards of waste from I believe it was, 2021 to 2022. It was an increase of over about 330,000 cubic yards of waste increased from 21 to 22. So
From a single outside contracted source.
potentially. I mean,
Yeah,
there is
I
more
guess,
local business they could have generated in that time frame, but a majority of that would have been from the contract they had with the Canadian company.
I guess my question really lies in the fact is that put them at a more susceptible place for having fires with that material versus other types of material.
If not handled correctly, it could, yes. But again, that's part of why we, with this vast increase of waste and the nature of the waste and how it was being handled, we went through the process of requesting updates to their operations plan, their landfill design, engineering documents of how that landfill was going to be constructed over time. To make sure the facility itself had that under control and was operating within the scope of the Washington Administrative Code that sets the minimum requirements for limited purpose landfills.
And of those requested, you may obviously have not met them because we have not renewed the permit. Is that correct?
Correct.
Well, could you also, Sean, go into the issue of when we did have the closure during the fire, talking to them specifically about the use of daily cover and how that worked because of the concerns around the ground up material?
Yes, when we did suspend their permit and ceased operation of that facility during their fire event they had last winter. When it got to a point, the fire activity was low enough and they had another area they can start placing waste. We worked with them on developing a temporary operations plan, which dictated, the side slopes of the waste would be a 3-to-1 slope, rise over run. That they would compact it into 5-foot lifts so that each cell of waste was 5 feet thick. And there would be a 12-inch daily cover placed over that. So we were ensuring that we got correct side slopes, a heavy rate of action of the waste, and then sealing it off with daily cover to inhibit oxygen intrusion. So we're not promoting the spread of the current fire that was there, but the starting of another.
So just to inform the board, as a follow-up, the issue was raised by Sean regarding the appeal that was done by Kate, and that hearing was held at the end of July. Dr. Varg issued his affirming of the denial of that permit. It was issued, his decision was rendered on August 23rd. It was provided to Caton. They have the ability to file a appeal with Pollution Control Hearings Board within 30 days of that decision. So that's where we are at on that process. At this point in time, we've not been given any notice that they've filed said appeal yet, but they have 30 days from the 23rd of August to request that appeal hearing.
Any further questions for Mr. McGee or Mr. Elliott? All right, thank you. So then we'll move back to public health partners.
Thank you. So for my update today, I'm going to be focusing on the health district's work around enhancing naloxone distribution. So just to reiterate, this the work that we're doing is specifically around naloxone distribution and patient access. Of course, there's the epidemic and many other partners who are looking at that as well. So Ed mentioned earlier through some of the comments that even with the different processing in place, like having the statewide standing order, having a mail order program and having people being able to go to pharmacies and get naloxone, there is a gap, and that's what we're trying to work on as the health district across the different systems. So there's a couple different initiatives that we've referenced previously. The first is reaching out to high risk, what the State Department of Health considers high risk organizations. So those organizations would be places like jails, shelters, or other organizations that primarily serve people who are currently using drugs, to provide them naloxone, and they reference them as high-risk organizations that can eventually become distribution centers. There is a little bit of a delay for organizations to be signed up as a distribution center through the Washington State Department of Health. And there is also a limitation that once an organization becomes a distribution center, their staff at that organization actually can't use that specific naloxone. So that's a gap that we are working on because in our pilot with businesses. So that's what we referenced before. So even though again, I'm going to be referencing a couple different types, and that just goes to highlight just the nuances between the access to naloxone due to the standing order in the meantime. Anywho, so what we're working on with organizations and businesses that are interested or are serving high-risk individuals is reaching out to them to see if they're interested in having naloxone on hand for their staff or to utilize at their place of business should someone have an overdose at that specific facility. Because again, if we as a health district give them that naloxone, they can't then use it to give it out to customers or anything like that. That would be considered distributing, which is not something that can be done with the current standing order. So unfortunately, McDonald's was our pilot program. They decided to no longer move forward at this point in time. But in working with them, we were able to put together all the training, all the agreements, answer all the questions that are necessary for other organizations that have reached out that are interested in having naloxone on hand. So there's a couple different areas in the works here in Yakima, and of course, we talking about reaching out in the Lower Valley. So at this point, I've talked about two different pieces. So this distribution center, and then also working with businesses. And then, and I do want to acknowledge that we'll be working with Dan, as he mentioned. That's another organization that is reaching out to businesses. So I know he's been working with Erica Ochoa, who's our community health specialist, working on this to make sure that there's not any overlap, and we're complementing our work in terms of businesses that are reached to provide Narcan. And then the third option that we've been working on as referenced was the vending machine, the two different vending machines that were purchased by the Yakima Health District. Again, referencing most organizations that serve what are considered high-risk individuals can eventually become distribution centers, but they may not have the capacity to actually track the naloxone or have a staff member dedicated to giving it out. And that's where a vending machine can also potentially help to make sure that streamlines some of those processes and procedures for the organizations that are interested in providing naloxone to the people that come to their facilities. So what the research shows is really that the highest risk of those that are at highest risk of experiencing overdose are people who are recently incarcerated or who are leaving treatment facilities. And for that reason, we'd like to further explore those locations as places to potentially place these vending machines. So that being in the jails or treatment centers. If that doesn't end up working out, other locations that have been shown to be successful are shelters, libraries, as well as hospitals and clinics. So again, another piece that we're working on to support this is obtaining the data to show where the different hotspots are, but there have been some delays on that. But of course, anecdotally, we have a good understanding based on our partners' experiences about where some of those hotspots are in Yakima and in the Lower Valley. So an update on the machines themselves, we've successfully been able to set them up. There's one in our lobby currently, of course, pending the conversation today. It hasn't been stocked. It's not something that's available for public use quite yet. But if anyone's interested in how it works, I'm happy to do a demonstration afterwards as well. And so that's the update that I have in terms of the work around naloxone access. And then just very quickly, one of our partners, they're still here. Triumph Treatment Centers is hosting International Overdose Awareness Day on Thursday, which is tomorrow, and it'll be at Sarge Hubbard Park. The Yakima Health District will be participating and providing naloxone to community members that receive training on how to use naloxone. And I know many other community members will be there providing resources and awareness on the topic. So those are the updates I have. I know there's another agenda item, but if there's any questions that I can answer now, I'm happy to do so.
I do. I'm sorry, go ahead. Yeah.
Oh, would we, when we're talking about, like when we offer the CPR classes, I'm just wondering, have we thought about offering classes similar for people who want to get educated on how to use Narcan.
Yes, yes, because that's one of the biggest, I would say, barriers for people wanting to utilize Narcan is that concern around, well, what if I hurt someone? What if I hurt myself? Or just many of the natural questions that come. It's a very intense experience to say, here, use this medicine and save someone's life. So that is something that we've been working on. There's someone in White Swan, Julie Schilling, I believe, and one of our board members actually attended one of the trainings. And so that's one of the supplementary pieces that we're working on, is how do we establish a train the trainer model so that everyone's comfortable in utilizing this resource, and it's not but that's not one of the reasons that people don't want to use it.
Yeah, in our ongoing discussion about using the Narcan dispensing machine, the vending machines, there was some initial question about an educational piece being offered with that.
Yes.
Can you talk about that a little, please?
Yes, so on the machines themselves, I'll just walk through it very quickly. In order to get the naloxone as it currently stands, there's a QR code that needs to be scanned, and a couple questions will be asked in terms of their demographics, their history using Narcan previously, and why they're getting it. Is it for themselves or for a loved one, things like that. And at the end of that, there will be information provided for, are you or someone you know interested in treatment services? So there'll be information there. There'll be information on the machine itself to help people identify resources, and on every single kit, there's also going to be so 2 different business cards, one in terms of how to actually recognize an overdose and utilize a Narcan, and also some resources for treatment as well. So there'll be various stages in terms of where individuals who are utilizing the machine itself can get access to resources. And again, depending on where the machine is actually placed, then potentially they would already be at a treatment facility as well.
Thank you. That's very helpful to know. Appreciate that.
Councilmember Byers, if I may, we purchased the nasal spray Narcan specifically because there are people who are uncomfortable with the use of something that is syringe based. And so we're trying to make it as simple and effective and less concerning for people.
Just a follow-up on the efforts to get Narcan kits in our businesses. What was if you're allowed to speak to it, what was the hurdle or the challenge that McDonald's faced of why they decided not to move forward with that program? Is it liability, insurance, or is there anything that they disclosed to us that we might see being a challenge or barrier with our businesses?
In this particular case, they just said they simply weren't ready.
Gotcha.
That was all that was shared. But I will say that it's, as I alluded to, as I talked about all these different types of naloxone and as I alluded to in terms of all the different ways that you can get naloxone right now, because it is technically something that needs to be prescribed. There is quite a few legal pieces that need to be considered and just spelled out. And I do think that that's going to be a little bit of a hesitation on businesses' parts when they actually see the agreement. They might get a little bit of a sticker shock. But again, given that the federal, I think the FDA did approve it as an over-the-counter medication moving forward, I do think that some of those pieces will subside. But in the meantime, over the next few months, it is something that we're going to have to deal with. And so we're working on how can we better communicate what this agreement actually means. And the agreement really is just to make sure that that these organizations aren't just considered distribution centers, and they're really only getting it for just their staff and to utilize on their immediate vicinity. So there's just some nuances and agreements that I think will potentially concern people.
Thank you.
Just a couple questions. So you mentioned the nasal spray here. Any feel for the effectiveness of the nasal spray versus the injectable drug? The injectable Narcan.
Yes, and I do think that maybe someone else might be better fitted to explain that in detail, but I do know that.
For real?
That's the other.
Well, we can speak to it.
No, someone raised their hand back there.
I don't know if you wish to take something from someone who's a guest, but
Could you address it, Mr. Fusco? We'll see where it goes.
Sure, and I won't do it justice to the way I would if Melissa was here, but really the harmful effects, especially of artificial overdoses, it's harder, so it takes more doses.
Of the nasal spray.
Of the nasal. No, I thought it really was, no.
I'm sorry, there's misinformation, and I don't blame you for this. So the question was, how does the nasal spray compare to the intramuscular injection? They are both dosed in a way that they are equally effective.
Oh, yes.
So it's not that it's a one-to-one conversion, but they're dosed so that it is. Now, it's true that multiple doses may be required for for a fentanyl overdose. There's actually a more potent product that's coming on the market that is, so the nasal spray right now is a 2 milligram dose with each spray. This new product is an 8 milligram dose with each spray, but the same effect can be achieved with multiple doses of Narcan. Sorry.
Thank you. You did that.
Well, just, I'm gonna follow up on that then. I'm assuming, you just mentioned it was intramuscular, and it kind of surprised me because it's supposed to be fast acting, so I figured it was an IV drug, but I guess not.
No, I am
Be given IV
for the
as well.
injection.
This one now?
It can be given IV as well. There's multiple routes of administration.
I have a question. Lillian, you mentioned a QR code on the vending machine. So is scanning the QR code the way to access the Narcan? Is that the only way to access it? At this point, yes, there, for every facility, for every closed facility, there's that, the host would receive like an emergency code basically to bypass all of that. But for community members going in at this point in time, given the models that we have looked at from the other counties across the state, it is scanning the QR code, answering a couple of questions, and at that point, it generates a code that gets utilized at the machine itself. These things, of course, if we find that they need to be changed, they can be. That's the beauty of a pilot, is we can test it out and see what's most effective. But at this point, that is how it is set up.
To your point, though, and you know, as far as access, I think it would be nice to have on the vending machine if someone doesn't have a phone where they can access the nearest Narcan. I think that will alleviate my concern for accessibility.
Absolutely.
Any other questions or concerns? I'm wondering, as our coroner, if you have anything that you would like to say at this point?
Thank you for asking. In reference to the QR code, I was wondering if there's like some kind of educational piece that can be made to the decedent or to the person. We are finding decedents with Narcan at their side. So if it's a chance that's developing a false sense of security, that they have the Narcan with them, but unfortunately, when they get to the point where they need the Narcan, they're not unable to administer it to themselves. So if there was some kind of a educational piece as to reference that if they are in trouble, they will not be able to administer it to themselves. I do believe that Narcan is a valuable tool that can be, if it's introduced into, if it's not there, then it can't be used. So if it's there, I think it's a valuable tool to have at the person's side. I just don't want the false sense of security surrounding the drug next to the, so yeah, and it's probably, I can't give you a number, but we see it quite often where the Narcan will be sitting right next to the decedent in their chair. And an unopened or partially open package.
Thank you, Mr. Curtis. I appreciate that. And I'm Lillian, you're shaking your head. I'm assuming that we can easily make that information available.
I appreciate that.
Yes, we appreciate that. Thank you.
Coroner, I have a question for you. It's been widely reported that most of the times that Narcan is administered because of this new, the makeup of the fentanyl is now becoming more and more dangerous. And so it's typical now to have multiple attempts at Narcan, something 3 or 4 shots, and that's what the Yakima County Sheriff's Office is also experiencing. Can you speak to that?
Pre-hospital paramedics are delivering. It used to be like with heroin, morphine, morphine. So it used to be with that, you'd give like 0.02, just enough to titrate to the respiratory rate. Now we're giving 10 milligrams of Narcan to try to turn it around. And oftentimes you're not able to turn around then you're going to support their airway and different things until you get them to the hospital. We're finding decedents with close to 30-40 times lethal dose of fentanyl in their system. So basically they're getting a counterfeit pill, they're smoking the pill, so they're getting that high concentration of the opioid into their lungs, into a concentrated blood source, which is in your lungs, and then from there it's going to all the receptor sites in the body. We're finding people with paraphernalia still in their hands, and so they're the lighter, the spoon, the straw, the tinfoil still, so that they are going down at the very time that they're using the drug. And so, yes, there is a very high concentration of it. And now we're finding it, or we haven't seen it yet in Yakima, but other counties are seeing where they're mixing ketamine and fentanyl. And so pre-hospital be able to reverse the opioid, hopefully, but the ketamine in conjunction with the fentanyl creates a very dangerous combination. And that's along with, we also are seeing a high concentration, quite a few people that are normally known just to use cocaine, but now they're getting cocaine that's laced with fentanyl. And so they'll have a very high concentration of fentanyl, and all that we're finding on scene is cocaine, paraphernalia, cocaine, what appears to be cocaine, but they obviously are getting fentanyl with it.
You know, we appreciate that.
Just, you know, hearing stories of people that just are encountering substance, you know, whether it be smoke or somewhere just out in public. So people just everyday citizens. So are you seeing that, or has there been any, you know, non-using people just out in public that encounters something?
So in the pill form itself, it's not as potent. So we are seeing fentanyl or powder, and that stuff can be aerosolized, like you think about talcum powder, that kind of thing. You're inhaling that can be dangerous. Yeah, and so, and I know in like in the hospitals, they've had instances where people would go into the ER room and people are smoking it, so there's still it's kind of in the air, but it's a weight dose.
I'm
So-
sorry, that's also not accurate.
People aren't smoking it?
No, so the hospital's actually working through this right now.
Excuse me, I am sorry, if you can answer that briefly and then not.
Yes. Thank you, I appreciate it. I'm sorry, but this is a rumor that's been spreading through town and it's not accurate. So I've actually contacted the University of Washington Poison Control about the incidences that have been happening in the hospital. I'm happy to share that as a document with this board, but the short answer is we have no verifiable proof of any occupational exposure.
Thank you.
What about commute? So I'm just wondering, have you seen any deaths,
Not
accidental
deaths,
deaths
no.
of people? That just
Not
ran-
that I've been aware of.
Okay.
So.
That we can maintain the discussion of the board, that would be helpful, thank you. Anything else, any other questions?
I guess said differently or more clearly is that so far we have not encountered, at least in Yakima County, an accidental exposure in a public area.
That's, I can only speak to a death, what I would be.
Other than law enforcement coming into contact when they are coming into contact with someone who has paraphernalia on them.
Right. And so I guess, I don't know if the information was false that I got, but there was an instance where people were exposed secondhand. But I don't have any evidence to prove that or not. So that's just word of mouth that I was told.
Any further questions? Next on the agenda is unfinished business, and we currently have no unfinished business, so we're gonna move on.
I add just something really quickly because we were asking Sean a series of questions and he just pointed out to me that he had actually accessed some accurate numbers to which I had asked. So I just asked if I could have him share that with the group.
Rudy, go ahead, please.
Yes, so I added up the total waste received by the Keaton landfill since 2018. So the 2018 to 2022 annual report, they received a total of 874,000, basically just shy of 875,000 cubic yards of waste. And they recycled 685 cubic yards according to their annual reports in that 5-year period. So that's a recycling rate of 0.07. Just, I wanted to get you guys the right number since you asked.
Thank you.
And yeah, they reported 0 cubic yards leaving the facility for recycling centers.
Which begs the question of, is there some way that we can discuss at a future meeting, not today necessarily, but at a future meeting, the option of having standards to be met with recycling.
Well, one could suggest that applying for one would be a real clear way to find out what's involved in becoming.
That's what I was thinking. Yeah, kind of start with having. it.
Start with that, yeah, thank you.
Councilmember Myers.
I'll brainstorm and have some ideas I can talk about with Ryan and Andre that maybe we can talk about at a future meeting around. Local policy. And things like that.
Go ahead, Mr.
No, I'm good. Thank you.
All right, thank you very much. Okay, then we move on to new business. And the first part is youth prevention for drug use and specifically fentanyl. And Commissioner McKinney brought this to the agenda. So before we get started, I'm gonna have you start the discussion on it. And don't know whether or not there'll be any movement on it today, but after you start your discussion, I'd like to have maybe one or two staff people respond, and then I'd like to give every member of the board an opportunity to weigh in before any further conversation was on. So go ahead, Ms. McKinney, please.
Well, thank you, and I do appreciate staff too tabling this and for everyone on the board because I was not able to be here for the meeting that I initially had brought this up. But I'll be brief because I think that we've just actually had a very robust conversation about the reason why this is incredibly important. I think it was spoken to previously about the nature of the addictiveness, but unfortunately, we're not even having folks who are necessarily are becoming long-term addicts of something as deadly as fentanyl because it is so deadly. I'm hoping, Lillian, and the point of me bringing this forward is that I have some awareness because of, and it's actually how I met Lupita was through outreach programs. It's with great efforts that they're doing, but the message needs to be far more expansive to reaching our young people about the fact that this is absolutely deadly the one time you try it. It is not something that you are necessarily going to be able to have your friend bring you back from. Just merely coming in contact with it could potentially be something. We're trying to help the person who next to you. It's not like, if I could say, when my parents grew up, it was, smoking a bit of weed. And I'm sure that while their parents, didn't condone it, there probably wasn't as much of a concern about it killing them in the moment. And so I feel very strongly that the prevention, especially with youth, is a very easy, clear way that as a society we need to focus on. It's just incredibly difficult to think that our kids might, in their exuberance to be like normal youth, like we all were, and test something out and they don't walk away from it. So I just was hoping that we could express dialogue on how we could potentially come up with a real proactive way to create something unique, reactive to our kids.
Yes, and one of the pieces of that we want to continue to explore is the great work that's taking place by the different community wellness prevention initiatives. That's what I had referenced previously. So now that school's back in session, that's something that we'll be able to explore much more. But there is a couple different education programs already in place, and seeing how we can support them, being that they are the experts already being in schools. So we definitely want to work with the existing organizations to see how we can expand their work. And then just for reference, it is absolutely at the state level a priority in that right now there's currently two different communication campaigns, one through the State Department of Health that's targeting adults, and then one through the Healthcare Authority that's targeting youth. So that is part of our efforts, as well as how can we continue to expand that message. But to your point, how do we make it specific to Yakima as well? And that's where we'll be working directly with those already working within the schools to support that. So that I know that those conversations have started prior to the school year ending, and we're planning on bringing those back up with, again, the community health specialist being Erica Ochoa, who's been working on reaching to these different schools.
So one suggestion I forgot to say, Lillian, is that one of the ways I think that we have an opportunity to reach out is not just through the schools, but through their after school activities, especially sports, because those are typically kids who are exhibiting some healthy lifestyle choices, and obviously there's that mentorship through coaching, also positive peer pressure. And so I just wanted to also say that I think that sometimes those after school sports activities would be an opportunity for us to reach them outside of even the classroom.
Yeah, no, I absolutely completely agree in terms of making sure that things are peer-based, as we know that it's always the most effective.
Oh, I was just gonna share, we've seen the best outcomes from community partnership approaches. And so what I'd like to gauge, we know that there are groups that are part of this. We know that ESD 105 is involved. We'd like to gauge where the barriers might be and where the support is needed, and then we can certainly bring that to the board's attention. I want to make certain that when we have these conversations, that the board is aware that that means that we are really encouraging and working directly with speaking to youth. And so we're excited about that opportunity. We don't want to see people trying something for the first time and then having a bad outcome. We certainly don't want children in a situation where they witness an overdose or even a death, which I think can be traumatic in and of itself. So we're happy to do that. And I would also share that, as you mentioned, there are other areas to interact with children. And there are kids who are vulnerable. So we'd love to do that across Yakima County.
Yeah, thank you. I appreciate Commissioner McKinney bringing this issue up. I mean, it's an issue near and dear to my heart because obviously we're not blind to the fact that addiction and substance abuse is a big problem. I think it's the biggest problem our county faces. And it's always wonderful to see positive results in things like treatment facilities, drug courts, therapeutic courts and the like, anything that can help bring people into a better spot and help them recover from these. But gee, it's so much easier and less expensive and less painful to keep people away from it. It's really the best solution. So I'd appreciate maybe a report back at some point, let us know, what's being done in this way now and how we can expand it.
Absolutely. I would like to add to that, there were times in the past when they were like using your seatbelt or things like that, that were done at a national level, a state level, a county level. I would like to find opportunity for us to literally flood our valley with information. And that can be with partnerships, but it can also be, how can we have people just buy into that and promote that? How can it be done on television, on radio, on every avenue, on TikTok, on social media, and every avenue available for our young people to give them. You're laughing at me, James, I know why.
Just name the rapper that you know.
Coaster, we could have Coaster.
Coaster, there you go.
So honestly, I'm not kidding about that. Is every avenue that we can find to get this very critical message out to our young people. And so I want to thank you too, Commissioner McKinney, for bringing this up. It's an important thing.
I would also love to have a report back on how the health district is partnering with the community coalitions and the work that's already being done. The youth prevention work in this valley and in this county isn't new. It needs to be supported better, and there's a lot of room to support it. And so I would love to see the health district get behind that and explore different avenues beyond schools.
Yes, and thank you for saying that. That's what I was alluding to earlier, is that this is going to be new work for us, but we know that there's not new partners. So that's what we want to explore first, is making sure that we're supporting the work that's already being done and being able to add in value where we can with this goal in mind. So yes, we can absolutely report back on that.
I'm thinking avenues like even youth groups, faith community, sports teams that are not part of the school. There are all kinds of avenues that can be used to reach our young people. So.
And their parents.
Yeah, and their parents.
Yeah.
And I would add that these community coalitions are grassroots coalitions, but they're made up of 12 sectors. So they have 12 different community sectors that are a grant requirement. They are attending, they're always there, every part of the community is there. And so, even the health district could be there. And so that also would be a great place to tap into connecting to people who are already doing the work.
And there could be financial benefit to that if there are grants available, if we are meeting the requirements for that, then to have grants available to support our efforts. Yeah.
And it seems like ad campaigns could also be, ad campaigns, personal outreach could be.
I think emphasis on personal outreach. I think tends to be where when you actually have a one-on-one conversation with someone, especially if it's someone that you love, it tends to have a lot more impact when someone looks you in the eye and says that I want you to wake up in the morning. And this is a danger, and this is why you should avoid it.
I know there have been previous educational opportunities in the community, and I've actually used some of them when I was working in the different capacities, teaching parents how to talk to their kids. And that could be an important part of the whole thing, is educating parents on how easy it can be to have discussions with their children about this.
And I think it makes a lot of sense. I mean, parents should be they are the first contact and are the most important, but also having had 6 teenagers, I've also known that sometimes they get reached by other people that come in contact with them, like teachers, coaches, pastors, etc. That could also, bring that message across effectively. So I think it seems like an all of the above approach, really.
Putting it, it's really all out war. And what are we going
Yes.
to do to win it?
Yeah, and on that note, I mean, I think we're all in agreement. We want to carry this over to our September meeting under unfinished business, but I don't want it to just be a discussion. I think we need those actions, and I think we need to lean on our health district staff. But what are those actionable steps that we as a board can make a decision that are bold in essence to take? And for me, it's all about the gaps in the system. We know the state is making this a high priority. We know the ESD 105 is making our school district, I mean, across the board, everybody makes it a priority, but where does the health district fit perfectly in the gaps where it's not being addressed? And we may find out that it is bringing a big keynote speaker into the valley to talk to all of our elementary schools, to really get them excited about a campaign that the state is working. But I'd like tangible action and options that the health district board can move forward with in September.
I would just say that I'd like to see Lupita take as much role as she's willing to work with Lynn, because excuse me, there's no sense in reinventing the wheel. And to your point, Commissioner, identifying the gaps. I think Lupita is the adept at being able to probably point out where some of those gaps are. But I think that she's a wealth of knowledge with the work that she's already been involved in.
And you're willing to step in?
I am.
Thank you very much, Rachel.
Thank you.
Thank you. All right. Any other comments on youth prevention? Okay, then we're going to move to part B, and we're going to do this much the same as we just did. I'm going to start with Commissioner McKinney, then maybe have 1 or 2 staff address this, and then give every board member an opportunity to discuss it before you move to the public. Please, sir.
Thank you. I appreciate it. And I know, again, we've already had a lot of robust conversation about this. I think for me, I know we've had several conversations as board members to the point that we're working on working with parents and schools and all of those avenues to try to educate. Those all have something in common, and that's people. And so I would just say that I would like for us to consider that when we have a vending machine, it is a cold hard machine with apparently a QR code. We know that when someone is potentially getting Narcan out of that, it's because they're going to potentially make a decision to inject something into their body that has such a high likelihood of killing them that they know it, and they're actually going to take something from this machine because they think that there's a high chance that what they're going to put into them is going to kill them. I want us to focus on that human interaction. I want us to be able to give that human interaction a chance. We've talked about how we're going down into the lower valley for self-harm reduction expansion. We've talked about the importance of having people there to be able to say to someone, I care about you. I know today's not your day, but I want to talk to you about the next day. And my only concern about these is that we're removing the human interaction. And I think that it can be cold. And I would like to see us focus on putting people in front of someone as much as possible. And so I wanted to open it up for dialogue.
Okay, I agree that the human interaction means more. I don't agree that the vending machines, that people accessing them are only those that are intending to put something in. And I do agree that the human element means more.
I agree. I mean, I have doses in the naloxone because I work with young people. And I want to be a resource that if I need to treat someone, and I went to the training class because I want to be able to save that life. And so to tell my students who are not have a drug addiction at all, but could very well have a family member or friend to go to a vending machine. So they have that on them and it's not a cost barrier for them to get a hold of it. The access.
I think in today's world, it used to be, we knew somebody who had a family member or a friend impacted by the fentanyl overdose. I would be shocked if we could find somebody today who doesn't know somebody directly who has had somebody impacted. And I think if you've experienced that and somebody's experienced that firsthand or even secondhand, you're probably people very willing and ready to carry.
Thank you. Dr. Atterbury, I know that you have some time constraints today. Would you like to discuss this?
Yeah, I would just add that, I mean, I share everybody's sentiment that the best solution is obviously not having people use drugs. And when we talk about the youth and the great vulnerability they have, susceptibility to overdose, it's a tragic problem. I'm reminded of, Amanda's point where she said, maybe my parents would have been talking to me about weed. I wonder if maybe if we had different attitudes back then, would we have different results now? It begs the question, I guess. And in my own life, I know that we see the direct results of people addicted to substances. And I really, I feel for them. I take care of them. I reach out to them. I interact with them daily. It's not a rarity to see them. Instead, I think the how we go about bringing about safety protocols, harm reduction, there can be robust discussions about that. I think the problem does not go away if you put your head in the sand. The problem does not go away if you wish it away. Frankly, the problem is here with us and in this valley to stay really for generations. And so what we do now may have an impact on those future generations. And anything that we can do to facilitate having people alive. I'm always reminded by the fact that you can only help somebody if they're alive. If they're already dead, it's over. You lost the war. So what we can do towards that end, I think we can all have great discussions on. I'm sure the community at large will have great discussions on, but I don't think there's an easy solution. I don't think a vending machine solves a lot of problems, and yet it serves a particular need that exists right now. So I understand both sides of it. I would say we should focus most of our attention on preventing people from becoming addicted to drugs. And then how we deal with the people that are addicted to drugs has to be humane, has to be well thought out, has to be something that we don't just do on a fly-by-night operation. It has to be designed to save the most amount of people possible, because this scourge is taking place in our community, as the coroner shared with us. And I know people directly, that my patients directly, that have been affected. So I can tell you this, it's not a remote concept to me, but instead I look for solutions that will help the most people the most effectively and directly. I also would ask a simple question. One of the comments made earlier suggested that many of the people using Narcan are giving it to themselves. I actually think that's probably inaccurate. I think probably most of the people given Narcan are administered by somebody else next to them when they overdose. The person in the overdose state is very unlikely to be in a position to administer themselves Narcan. So it's who's over Johnny on the spot that's going to be administering it. I guess that's just a point of clarification. But nonetheless, I appreciate all your inputs.
Thank you, Dr. Atterbury. Commissioner Arquette.
Yeah, I wanted to, since we had Dr. Adler here for a minute, I was wondering if he might know or someone else in the room might know. I've never heard anybody speak to this, but are there any potential negative consequences from the use of Narcan itself? I see some head shaking no in the room.
No, we've done extensive research on it and spoken to experts, and it really is, it's a wonder drug in a sense, because it does not have a negative impact. And so that's one of the reasons why an individual using it really is free from the fear that they could hurt someone by using it. In fact, it's quite the opposite, by not administering it.
Thank you for that. I guess I just wanted to follow up with a comment that that this is a huge problem in our society, including in our county. And I would have to agree with Dr. Atterbury's statement. I think he was alluding to the fact that this has been a problem a long time coming, and I think it's really its roots are in really society's lax attitudes towards substance abuse for too many years, and we're reaping those consequences now.
Thank you.
I wanted to honor the board's discussion, but I'd like to share something.
Andre, though, you just said, though, I just have to ask you to clarify. So you said that if by not administering Narcan to someone that you are harming them. And I just think it's fair to clarify that the harm is definitely done by the person, that obviously there are people who might be taken over by fear and not able to help someone. I certainly don't think we want to put someone in the, okay, I just want.
Let me restate it. You're not adding to their drug addiction or causing their demise. But I'm just sharing that trying in the best case scenario to care for someone in a time of need is admirable and doesn't have a medical negative effect.
We have laws that protect you.
Yes, 100%. Which we can also clarify, and when we were discussing the idea of education, whole community education, I think that's one piece that even when we say things like Good Samaritan law, it's a very obscure way of speaking. You're not going to be held liable if you try to help them.
Of course, you won't get in trouble.
Yes, 100%. And I think that's great. And the language we use around that is, again, sometimes very formal. You're not going to be, you're not going to get in trouble for trying to help somebody.
Yeah, and we tailor all of our communications depending on who we're talking to. So absolutely, yes, because we don't want people to feel.
I'd like to give Ms. Carrillo an opportunity and Ms. Atkins an opportunity and Commissioner Curtis an opportunity to speak.
Any information on other areas that have had vending machine or have a vending machine? What the outcomes have been, their experiences, pros, cons, issues?
Yeah, there's actually quite a bit of research that's been done over the last 40 years since vending machine for naloxone dispensing vending machines have been in place. There hasn't been any major negative outcome. I know that there's always concern about vandalism and things like that, more operational pieces that tend to be concerns, but what the evidence has shown is that they do reduce overdose deaths, the rates of overdose deaths in the different studies that have been done. That can range anywhere from 10 to 50%. It just depends on the community. And so overall, it does have a positive impact in terms of reducing the deaths. And there are similar concerns in many of these other communities. And again, there hasn't been any major negative outcomes that have been identified. And I'm happy to share those with whoever's interested as well.
And I just have to say though, that it's not yet there's a correlation though, because there's also been in those same communities, an explosion in the use. So I think you can't look at it just in the lives that are saved, which is important, and that does not take away from it, but we also have to see that we're also seeing increases. And in fact, Washington State, Oregon, California specifically are seeing massive increases in the people who are using these drugs compared to other parts of the nation, which is why the Attorney General, Bob Ferguson, is actually asking our Department of Justice to actually target Washington State, Yakima being one of the areas, because while the rest of the nation has seen a 3% decline overall, Washington State specifically has seen a 21% increase in the people who are using. And I know that the coroner is not here, but we're also seeing increases in overdose deaths as well. So I think it's important I think what you're driving at is there's a lot of data here. There's some pros, some cons, and I think that we need to look at all of it. Thank you.
You have any further discussion questions?
Okay, so correct me if I'm wrong, but I'm hearing, or I heard earlier that there is Narcan available in this community. We have Narcan training happening in this community, so there's access. We heard from someone in the audience that there is access via 911. Is that correct? I don't. AED advocates.
Yeah, not yet, but coming.
Oh, coming. Okay. So there is access at this point.
There is access, but it's still limited in terms of people that live in rural areas and for people that don't have insurance, and you still gonna have to pay $50 to $100 every time you go. Again, awareness, I mean, even the fact that that agencies can be a distribution center, that's still a big question mark for a lot of organizations, and these are organizations operating in official capacity. So there's quite a bit more work that needs to be done to make sure that there's not naloxone readily available across the community. And that's what I was trying to get at earlier, is it sounds great, there's a standing order, you know, you can walk into any pharmacy, but when you start looking at how does that actually look like operationally, there's still quite a bit of gaps. And so that's not to say that there's not any Narcan available. As I mentioned, it's 1,000 between our syringe exchange program alone this year, but there's much more that's needed, much more that can be available once we connect all the pieces. So I completely agree that this is not the standalone solution, but it is an important piece of the puzzle that people are trying to address. So I do think that everyone is more or less saying the same thing, that we would love to make sure that naloxone can be distributed by a person. You can have that personal interaction, but sometimes people aren't necessarily going to want that. Some of the machines themselves have been shown to reach younger communities who don't, who feel more comfortable. But again, that doesn't mean that that's the only option or that's going to be the only service available to them. And I do think that that's something that we're all keeping in mind, is that we have to look at the entire picture and try to address the pieces where we can, and not just say this vending machine is going to be the only option, but it is an option. Thank you.
You said it's a pilot. What does that mean?
The pilot was really more or less to get the kinks out, to make sure if there's, you know, some of the coils get stuck, that we know that, and we can tell people before they start utilizing it. Is more or less just to figure out the operations before we started reaching out to different businesses to host it. So the last thing we want to do is ask an organization to host it and then they start having issues. We wanted to make sure we know all the logistics and the issues beforehand before we ask someone to take that responsibility of hosting it. Thank you, Mr. Riddle. I appreciate that, Commissioner Curtis.
Yeah, I'll just add, you know, I don't think access to Narcan is limited in our county. I think it's extremely limited in our county. And that was one reason why I'd asked Andre to bring this item to the health district agenda, is because I realized that unless you were an active user and you readily were accessing the harm reduction mobile unit, or you were going to providers who actively had it available for you to access, the general public doesn't know where to get Narcan. Yes, the state has a plan, but the state's plan is lagging. It's taking forever for us to get over the counter Narcan. And so I felt it evident that for a county that has the highest percentage of overdoses, we needed to do something as a health district. And yes, Narcan machines aren't the answer, but it does fill a gap in the system. And to me, it was the access. It's providing an opportunity for the general public to know that at any point in time, there is that vending machine, whether it's at the Valley Mall or all of our public libraries or outside the jail, that they can show up to in the middle of the night because they're concerned about their son or daughter who's potentially using, and get that free resource. You know, yes, the state has a free program, but it takes you 5 days to get it in the mail. And I did that, and when I got it, one of them was already outdated anyway. So, you know, there's just continues to be gaps. I will say, I do notice on our agenda that it says a formal vote, and I don't know, Council Member Byers, if that's where we're ending the discussion, to take a formalized vote as a health board to.
I think that we just have a discussion, and if someone wants to make a motion, they can do that, or we can simply just end it with the discussion.
Gotcha.
Well, in fairness to Commissioner McKinney, she asked for a vote. So I do want to respect the fact that a board member requested it. That's why it's on the agenda specifically this way.
Okay.
But it's, and I certainly know.
Well, for procedure though, it would still need to come, I would still have to make a motion and it would have to have a second. So I'm just because I asked for it doesn't mean I get it.
I was wondering on the other communities that have these machines, is there any way they know or see, are people accessing it in the time of need? Or are they getting it to have with them on hand? Is there any, do they know that, or is there any feel for that?
There is, and I'm sorry, I don't have that on me right now, but that is a question that's been asked, and I apologize, I don't have it ready to be able to provide that answer, but I can follow up immediately after this.
Two quick things, although Jim Curtis did say, you're finding it in people's hands, you don't have time to give it. If you wait that long, you can give it to yourself. So if somebody doesn't have it on them to go get it at a machine, but then it's something needs.
Right.
And then to try to lighten it up, I remember I did share, that county of the vending machines. They agree in the directions and the instruction piece because the elder population was thinking it was nasal spray and.
No. So then what does the vending machines solve if that, if the people have it by them and
So
is
it's
it getting used by them or anybody else?
for people that want to have it on hand to help someone else when needed. Or someone who has a
Which you could do through the
prescription,
mail order
but it takes 5
or
days.
through the district.
Pharmacies as well.
You can't.
Have
put pharmacies,
pharmacy.
But let's say if somebody doesn't have the money to go buy it, right now Narcan's pretty expensive. And it does outdate quickly and not everybody will use it outdated, like there is some of that effectiveness still
We
in your
need
shit.
that training that it's 99.9
It is.
effective, even with it.
It is. We won't give it if it's expired, but we will save it for maybe Doctors Without Borders or something, give it to somebody else to give it. But I do think that the importance is people that want it and want to have access to it because they have a family member, a son, a daughter, whatever. It's important to have it and they maybe can't all afford to go get it.
I think then that there's still another solution, though. It doesn't have to be a vending machine. It can be that we actually work to make it readily available in a way, though, that people have to interact with a person
Well,
so that they can actually, you just, I mean, that's a wonderful thing that you just brought up. Someone could look at it and say, oh, I might have to throw this out because it expired yesterday versus, someone who had the knowledge, as you just mentioned, that they actually went to a small bit of training or having an interaction and find out that actually they can use it and still retain that. That's the important piece that, I mean, let's be honest. I mean, most people don't read the instructions when they're opening up the milk carton. We're expecting people to take something from a QR code. It's so unpersonalized. And I think it's really important that it's part of the stigma, I think, is because we're all doing this behind closed doors. I think it's important for us to actually talk about it. And the more we talk about it, the more awareness we're going to build around it and reduce the stigma. But the only way to do that is to have interactions so that people can talk about it.
So I'm, with the harm reduction program, I mean, it is being given out to the high risk community and they have easy access to it. And there are people that I know that since, it's a hot topic and a lot of discussion and, they are ordering it. They're ordering it or they're getting it through the pharmacies to have on hand. Like 10 to 15 people discussion, none of them would go to a vending machine to get it. They said they're ordering it either through the online order or through a pharmacy. So again, who are we going to be helping with this? And then what if they don't have a cell phone?
Yeah, so I just think it's important to keep in mind that we have to do multiple approaches. So even though some people being more comfortable with mail and that's the whole point of working on a systems level is how do you layer all these different approaches to make sure that as many people as possible. As I mentioned, younger people are more likely to access these Narcan vending machines, and what I referenced earlier was potentially putting them in jails or treatment facilities, because again, that's where people are at the highest risk. So as they're exiting incarceration or they're visiting a family member, people can just pick it up. And so again, definitely want to make sure that it's not the only option available, but I do think that if we have the option to provide more resources and more access, let's layer that on top of all the other great work that's going on in the community.
Lillian, what you just said is even more cause for concern for me, saying that it's the youth who are going to be potentially accessing this more. Those are the ones that we need to get in front of a person to explain to them the dangers of it
I know that not everyone accessing is because they're intentionally using it, but the reality is that without those conversations, there are going to be a lot of potentially kids saying, oh, well, I'm gonna have this on hand just in case, and I'll be able to save my friend, or they'll be able to save me, and then make the choice to go and do risky behavior, thinking that they've got to get it a jail-free card, which is not the case. We know it's very deadly. So I just continue to feel that I agree with all of it. We need to get as much information as out there, but I think it needs to be with human contact.
Commissioner Curtis, you had a question or comment?
Well, I'll just counter that thinking. I would say for me, that human contact for the reality is for a lot of folks is a barrier. It is. There is negative stigmatization with Narcan that if I'm going to go and I'm requesting it, that I'm going to be viewed that I'm a user, whether or not that's true. And so I just think the vending is a very unique opportunity for us to provide an additional pathway for community members to access a resource that they're otherwise aren't going to be able to access. So.
I also, Mr. Fresco, you had something you want to say?
Yes, I just wanted to share that it's a robust discussion and I welcome it with the board, but I'd like to get back to the point that we really are in crisis in our community. This is a community that is full of addiction and full of people who are suffering and people who are dying. And the discussion of where we receive Narcan is an important conversation, but it has not saturated our valley to the degree that I think that everyone is safely having access to it. Also, those who are looking for it for different reasons. I think there are many people who are very, as Ms. Ackerman mentioned, who want to receive it through the mail. There's others who are receiving it because they have known drug issues and they're receiving through a harm reduction program. But there's a vast majority of people who are not getting access to it and don't know how to get access to it and may not be fully aware of how to follow the process. And it is a complicated process. Also, there are many people in our valley who are modest, who do not have $50 or $100 to spend on it. And so getting it for free is necessary because the process of moving forward is not expeditious, it's not quick, and we're not at the point now where everyone has access to it yet. So what we're trying to do is solve a crisis issue, which as many of you have addressed, can lead to death on your first attempt. And we also know that there are people who come in contact regularly with people that they care about and love and know through many different social settings and are afraid that they might encounter someone who is addicted. And so the idea of having access, more access, is what our goal is here at the Health District. We purchased the naloxone to support businesses because we recognize that businesses are encountering this in a great deal, but they cannot distribute. We may distribute through our naloxone program and others are looking at distribution, but it's not happening quickly enough to save the lives that we're trying to save. Commissioner Flitz's point about those who may not be interested in contact, there are people who are embarrassed or ashamed or recognize that they have a loved one who is in crisis, but they don't want to admit that they do. There are many adults, young adults, who have friends who are addicted to drugs or who are in risky behaviors. There are people who have parents who are in risky behaviors, and they want to do all that they can to reach them. So the idea of having another outlet where they can get a life-saving medication for free in a shame-free environment is our goal. It is not the only answer, and it is not the only way to reach people, but it's been my experience in a rural community that has many issues to address, impoverished communities where we don't have enough clinicians, providers, caregivers, social service agencies. No matter how hard each and every person works who loves this community, wants this community to survive, there are not enough people to reach every person that needs at that moment the assistance to care for all these loved ones that we want to see saved. So we want to go to great length to have options. And one of the options is simply to have it readily available through a process. The other reason we find it interesting is that we can track some of the information through the QR code, which can allow us to have more information about where our targeted areas are, because we want to receive support to communities that are in crisis. The more knowledge we have about where those hot spots, as we say, that's also our goal as well. So this is not the only solution. We don't hang our hats only on a vending machine, But we do want to take advantage of the fact that other communities have used a whole community approach and it saved lives. So that's our bottom line. We are trying to save lives in a crisis and the answer is today.
Is there any further discussion?
So
Commissioner?
I think it goes without saying, the health district has already purchased 2 vending machines. We're moving forward with a pilot program, and normally I wouldn't ask this board to dive too much into the details, but since it is a pilot program, I think it would be worthwhile to at least have a discussion of the placement of these vending machines.
Sure.
If you're okay with that on.
Sure, absolutely. We're very interested in where they're located. One option, as we discussed, well, there's a number, but we have read research that says that if you have a vending machine at a jail setting or a welcome center or a reception area, if you will, at an incarceration facility, that those who are leaving incarceration have access to it. Those who are visiting, caretaking individuals have access to it. That's one area. Another area that we found again is addiction and recovery locations where people have known risk behaviors and want to be careful. And also, even if they're in recovery, they often have friends or family who are not in recovery, so they know people who are in addiction, in the throes of addiction. We have areas of our community where we know that there's a great deal of interaction with people who have addiction issues. There are places like libraries, and I can't speak because we haven't had those conversations, but there are locations in libraries that we've had in other parts of the country. So we're open to where it is. Our goal is not to predetermine where a vending machine is located. And if we place it somewhere and it doesn't have a high use, then we could move it. This is really about trying to address an issue of safety and availability for people and reaching people where they're at. It's important for us to go to where people are to make a service available. We cannot expect them to come here to receive all of their education or training or even naloxone. We want to be more responsive to them. So I'm open to where it's located and I want to go where its best use is benefiting the community. We can bring you more options, but again, we don't want to move forward if the board is reticent for us to use it in the first place. We've had multiple discussions about it over the last few months. The purchase was intended to reach people in a crisis. I think it's important, again, to gauge the board's support in making certain that our use is seen as positive as opposed to detrimental.
So to that point that you just brought up, that you mentioned that some treatment centers, so if this is something that even a treatment center would support, do we already have treatment centers right now in Yakima County who have vending machines in their lobby?
No.
So begs the question, if we already have identified in the community, people who are educated with treatment, why have they not gone forward with purchasing vending machines to stick in their lobby already?
Well, I can speak to that very clearly. It's an expensive process. I mean, you have to buy the machine, it's expensive, the naloxone is expensive. And not every organization is allowed to place them because you have to be allowed to do this type of work. So a medical setting could do so, we can do so. I mean, I'm open again, if it can be located in a partner's lobby, I'm open to that. And I don't want to speak for any of our addiction or substance use disorder partners, but if they were welcome to it, I'd welcome it. If it wasn't being used, obviously we would talk about wanting to move it, but our goal is to place it in a location where it's beneficial. But I will share with you, in a resource poor environment, spending tens of thousands of dollars on this is hard. So our goal has always been to serve as a catalyst and a provider of resources to reach the community in partnership.
I guess it comes down to what problem are you trying to solve? And I think what you bring up is actually a good point, though. If this was a problem that we're trying to solve on behalf of someone else, why did they not already do so? And I don't know that it's resources. I'm just wondering if it perhaps runs contrary to what they're trying to do. But I don't know that that's a health district problem to solve. It just seems to me if there's going to be a pilot program for something like this, the treatment providers themselves would be the ones who would want to try to pilot it and see if it was having the impact that was desired.
Well, yeah.
Go ahead.
I find that many of our partners are gifted clinicians, providers, educators, experts in areas where they are finding barriers to providing quick solutions to care. And we have talked as a board that this is a crisis, a concern. We are seeing death at higher rates than we would anticipate. We're seeing the very real concern that an individual, a child, a young adult, an older adult could take this for the first time and literally die. We know that there are people who are being impacted at all levels of the community, societally, medically, emotionally. It is a tragedy in real time. So what I'm sharing with you is that our goal at the health district is not to be in charge of this process or solution this process, but to work in partnership where there are gaps. One of the gaps we found was a very real recognition that businesses were very concerned about this and were finding overdoses in our valley in ways that we would not ordinarily participate. And so we are seeing very real circumstances where people are overdosing in bathrooms or in parking lots. Our goal in purchasing this naloxone and the ability to distribute to businesses, but also make it more readily available to social service agencies and the public is because of the so again, I'm sharing with you that not every organization has the means, the staffing, the knowledge, the ability to solve this. And certainly many well-intentioned organizations in our valley don't have the financial resources. So the goal is simply to provide a life-saving medication to those who wish to receive.
Andre, question for you. Is there a part or data available on where overdoses are happening from either the sheriff's department or the county's police force to tell us where these things are happening? Obviously, one location that makes a lot of sense is the jail. That's pretty obvious. But outside of that, in a public setting, for instance, the Greenway, the largest public park we have, is there any data we have on where overdoses are mostly happening or being picked up?
Yes, there is data available. The data that we currently have is related to the deaths only, but that's what I referenced earlier, that we're working on getting the non-fatal overdoses as well. So we do anticipate having that here shortly and working to be able to map that and hotspot it as mentioned. But of course, you're right. I mean, working with our partners, we know where anecdotally and through their experience, we're seeing those increases as well. But yes, that is our intent always to make sure that it's data informed, either with research in other locations that have been successful, or once we have the data, being able to identify geographically what are some organizations that would be able to host something like this, given the data.
Thank you, Chair Myers. Listen, it's been a long and robust discussion, really thoughtful, and a lot of good opinions expressed on all sides of this. And to me, it's not an easy and clear-cut answer on this issue, but I guess I would say that to me, we've never faced an issue like this, like something that can kill you the first time you try it. I mean, on such a frequent basis. And I guess if I have to err in some direction, I think it's going to be err on the side of where we can keep people alive. And so therefore, I would move that we support the Yakima Health District's pilot program to install Narcan vending machines, and we monitor it.
Commissioner Lindy, would you accept a friendly amendment?
Let's see.
My amendment would be that the health district deploy these vending machines no later than October 1st, and that one machine be deployed in the upper valley, one machine in the lower valley. And the preference is also that the machines must be accessible 24 hours a day in a well-lit public area.
Yes, I'm amenable to that.
And I will second both of those. I just want to add a couple of things.
Wait. That's for discussion. So we have a motion to have the health department to move ahead with the vending machines. We have a friendly amendment that be done in a specific way. So before we take the first amendment, we are going to vote on the friendly amendment. Yeah, we need discussion to the friendly amendment.
But I'm happy to wait for the board.
I do, I just, from staff, is that doable, a 24-hour access well-lit kind of situation? I mean, is that even a possibility?
It can definitely be a priority, but there are logistics and operations pieces that go into it, but I do think that would be difficult to. Given the internet requirements and just all the things that you don't want to know. But that is absolutely always a priority to make sure that that can be a priority.
So what is possible then? So that's not.
Just
Logistics,
finding a willing partner that has, you know, a good internet connectivity, people that a location that's staffed 24/7. I mean, those are pieces, but it's a little bit more difficult when you take in all of the logistics into account. And but just given our experience setting it up here at the health department in and of itself.
Any other?
So it sounds to me like it is likely not be expected that all of the requests that Commissioner Curtis just put forward would be.
I find that hard to believe, to be honest. I think if it's the will of this board, I think it can happen. I think we can.
That's all I wanted to share, because I'm not against any of this, but I don't want to have an expectation through a vote, which we can't honor. I'm sharing with you that having 24-hour access would be ideal, but it has to be in a safe location where it's not vandalized or stolen. It has to be in a location that makes sense. If we find 24-hour use, but it's not being used, then it doesn't meet the criteria. We have to find a partner that is willing to host it and willing to work with us and willing to ensure, as you said, the integrity process, and it is available for others. Absolutely goals that we want. And as was mentioned, Upper Valley, Lower Valley, exactly what we are looking for. This is an equity platform. It's an available resource. But we have to make certain that it's clear who receives it. If we, for as an example, put it in a jail and it's open 24 hours, wonderful. But if they have visiting hours only certain times, that may limit the ability. Not everyone's going to want to go to a jail. And so, you know, these are conversations I want to make certain that we can honor. The intent, we agree with 100%.
Any other discussion to the amendment? If not,
I
I'd
would
like-
just
I'm sorry,
add.
Go ahead, Dr. Atterbury.
I'm sorry, I would just add that the timeline of October 1 seems kind of quick. But none, I mean, if it's possible to be done that fast, then okay, but I would hate to hamstring us with a deadline that's not actually attainable.
Any other comments? And like a show of hands from the voting board members, all of those in favor of the friendly amendment, please raise your hand. All right, all of those who are not in favor of the friendly amendment, please raise your hand.
Can you reiterate
Can you repeat? Please?
Yeah, absolutely. So my friendly amendment was by giving a deployment date of October 1st, no later than October 1st, with the requirements that one machine be located in Upper Valley, one machine in the Lower Valley, and that it had to be accessible 24 hours a day, and it was in a well-lit area.
So, okay, so I'm going to again ask because I missed a count here. So all of those in favor of the friendly amendment, please raise your hand. Any opposed? Right, then the friendly amendment passes. Thank you. It's 4-3 votes, 4 in favor, 3 nays. Right. I do what I missed.
I got 4-4.
I couldn't see.
Dr. Atterbury.
I'm sorry, Dr. Atterbury.
Against.
Okay, I missed you, Dr. Atterbury. Were you saying yes or no to the?
I voted against the friendly amendment only for the reasons I mentioned, not because I'm opposed to the idea of the vending machines.
Not a
5
vote.
yes votes.
Okay,
Wanna
raise your
re-vote?
hand.
Do
If
it
you're
again.
voting yes, raise your hand and leave it up, please.
So the friendly amendment.
Friendly amendment.
Friendly amendment.
Okay.
All right, and then those opposed. 4, I'll say, so then the ayes have it. It's a 5-4 vote in favor of the friendly amendment. Thank you. Now we're going back to our amended original motion. So we have an original motion that the health district move ahead with the Narcan machines under the conditions of the friendly amendment that it be initiated by October the 1st. One in the Upper Valley, one in the Lower Valley, 24-hour access and one. Right? All of those in favor of the motion, please raise your hand. For a yes vote.
And you too.
Yes, if that's five,
Is your hand up?
yes, I'm sorry.
I'm sorry, I'm confused. I mean, I am for vending machines,
Yes.
absolutely. I wasn't exactly for all the restrictions. I think that the health department staff. So I don't know if, I don't want to vote against vending machines. So I don't
If staff
understand
isn't
what
able,
this is.
Go ahead.
I'd say if this motion passes and staff is unable to accomplish it by October 1st, we'll know at our October meeting and we can move forward with other action. I mean, that's the reality.
Of any of the items that were just.
Yeah.
It has to meet all the criteria.
Yep, that's the request. And if it can't be met by October 1st, then this board will
Reevaluate.
reevaluate in October.
Well, it seems like it's really a goal, what we're talking about.
Yes.
It's a requirement.
So just so we're clear on where we're at, we have a amended motion that is on. To answer your question, if there are not sufficient votes to pass this amended motion as is. So if it falters, there could be a second motion for something different than including those terms. That could still also take place. So to address your question, if this amended motion does not pass, an alternative exists for the board to make a different separate motion that changes or alters the friendly amendment that was made by Commissioner Curtis. Does that make sense?
Yes.
Okay. Sorry.
Thank you for the clarification. Go ahead, Mr. Fresco.
Thank you so much. I again, welcome the interest and the support in reaching our community. I want to share with you plainly that we normally have meetings with our board during our board meetings. So October 1st, I want to make certain that we're clear because we won't have another time to meet until the end of October. I don't want to move forward with something if it does not meet the expectations of the board. The administrative procedures are ours to figure out. If we are being told how to do it and we can't do it, I don't want to reach October 1st and not be able to. So we're in August. That means that I think we should be having these conversations at the end of September. Because as an example, if you find a committed partner who's interested in hosting this and it's great, but it's not 24-hour access, does that mean we shouldn't move forward? Because then we're not moving forward and we're not beginning the process of actually moving. Now we're moving into how we as an agency do our administrative day-to-day business, which I think can actually be quite restrictive, which doesn't allow us to help people. So I want the board's involvement. I welcome the discussions, but I would like clarification politely from the board about this, because if it's 18 hours a day versus 24, we're not actually meeting the standard. I don't want to restrict our ability to help people, but I also don't want the board to feel that the staff has been working unilaterally without your support. So this gets complicated.
I think the board just made it pretty clear with that vote, though, what the expectation was.
There were some questions about how people actually wanted to vote, so I'm going to ask again. With the amended motion, if you wish to pass the amended motion, then please raise your hand.
Okay, well, never mind.
So there's already been a vote taken on the
amendment.
friendly amendment that already passed. So the motion that you have, I would suggest read the motion again and take the vote. I want to make sure we're clear. We're moving in different directions and make sure we have it right. So
As I understand, I did not write it down, but as I heard Commissioner Lindy's recommendation was that the health district move forward with the vending machines pilot program. And the friendly amendment that goes with that is that it's done by October the 1st, one lower valley, one upper valley, 24 hours a day in a well-lit area. So if you wish to vote yes on the amended motion, please raise your hand.
If you're in favor.
Yes.
With what you just read.
Yes. 1, 2, 3, 4. If you are opposed, please raise your hand. 1, 2, 3, 4, 5. All right, then the motion fails. The opposition is 5 to 4. All right. Is there any other move or discussion from the board?
So I need to move that the health department places the vending machines in locations that are the best fit with community partners.
Trying to accommodate those things, and if they can't.
Okay, it's not a special clarification, we have a motion that the health district move forward with placing the machines. Can you repeat that, please?
With community partners fitting the best criteria possible to reach the number of people possible.
So we have a motion.
I'll second the motion for discussion.
Thank you. So we have a motion and a second that the health district move forward with placing both of the vending machines, working with community partners to the best criteria possible to reach. That is our motion and a second. You made the motion. Would you like to discuss it?
I just feel like the health department is gonna do their very best to put these vending machines in places that are gonna serve the purpose. And if we put, as a board, put all these restrictions on it, it's gonna limit their ability to do their work. It's just these vending machines, we have the Narcan, like Commissioner Curtis said, let's get going on it. But we can't get going. We're gonna limit our ability to get going if there's too many restrictions.
As a second, do you have discussion?
I agree with the sentiments. I think the reality is this board, at our monthly meetings can always provide our insight and, look at the data. And if these machines aren't being effective, we can always propose alternate locations.
Do we have anyone else who wishes to address the motion?
I would just say that it might be that the placement that's identified might be a place that not every board member might agree. There could be some situations where, for example, what if that location was immediately next to, adjacent to, across from a elementary school? Maybe there would be community members who might, have something to say about that. If it was near, we named some facilities that might be good places. It might be some places that the board might decide that would not be. So just getting it out there to get it out there may not necessarily be the best course of action. So I would simply say that perhaps it would be best to identify the areas that have come back. You could come back and say, these are the businesses or areas that we have identified. They have said that they are willing to have it. These would be the criteria. They could have it lit 14.5 hours a day, all the things, and then the board could make a decision. So I would just say that I think at this point, there's too much that we do not know. And that it seems best that we receive more information about where these items would be placed. Thank you.
And I counter that again, these are the health department directors and staff or professionals. They're not gonna put a vending machine in a place that's not appropriate. And I trust their ability to do their jobs and not try to nitpick that.
So I'm going to give the rest of the board the opportunity to respond before you speak again. Anybody else on the board want to respond to the motion?
I would just bring up a friendly amendment, if I'm allowed, to the motion. A friendly amendment to the emotion that, to the motion, not emotion, to the motion that we table this discussion until our next meeting, and then site locations can be brought to us at our next meeting, and we can vote appropriately with the most data in front of us as to where they're going to put them. We all have ideas of where they maybe should put them, but I would put a friendly amendment to table the discussion and put it off till the next meeting so that we can get more data from all of our partners.
A point of order, I don't know if you can do a friendly amendment to actually table a motion.
No. So we have the motion's been seconded. The discussion is going on right now. The next step would be a vote on the motion as it is. To the extent that there are not sufficient votes to carry the motion, then there can be another motion after that. So right now we are motion, second, discussion. Dr. Atterbury has shared his suggestions, but amending in that fashion is not.
timing is
I'm
not
sorry.
correct. No, that's correct. You're right. That timing is incorrect for that. So, any other comments on the motion as it stands? Call the question. Okay, so the motion is that the health district move forward with placing the genes with community partners in the best criteria possible to reach the most people. All of those in favor of the motion, please raise your hand. One, two, three, four, five. All of those opposed to the motion, please raise your hand. One, two, three, four. Motion passes 5-4. Yeah, go ahead.
Yes, I wanted to share that I understand the sentiments that the board is raising, and in this period between now and when it will be placed, I'm happy to ensure that we are in regular contact with you individually to talk about it, to hear your concern, to share what we know. We don't want this to be a decision it's met with concern. It really is about trying to find the best locations. And in fairness, we're in crisis. We're trying to do something real time that's really hard to do. So, so we don't know where the best locations are yet, or the willing partners, or the availability, but we're happy to do that and do that very quickly and share that information with you. And that doesn't have to wait until the next board meeting. So everything you're saying, we agree with in terms of trying to prioritize the best place for it, the safest place for it, the least concerning place for it, and the timing issue and the 24 hours a day. I welcome all of that. We just want to bring you what is possible, and we will do so very quickly and share that with you all.
Making sure the ongoing communication would be helpful.
Thank you.
But just to be clear, it's only communication.
Not decision. No decision.
Well, I can, if I may speak candidly as the executive director of the agency, my goal is not to make decisions unilaterally that cause harm or cause concern or dismay to this board. The goal is to try to find best locations, and what I'm sharing with you is how quickly can we do it. It's dependent on what we find from our partners. So that might be a week, that might be 3 weeks, that might be 2 months. And so I really don't know a lot of the specifics, nor do the staff. So we're trying to do gathering of information and share that real time. That's our goal.
Any further discussion? Any further motions? I just want to thank the board for being present today, for all of your insightful, thoughtful input, for the consideration of the difficult discussions we've had from executive session until now. So I just want to commend you on your work today, and thank you very much. There's nothing further. I would entertain a motion to adjourn.
Move to adjourn.
Is that a first and a second? So we have a motion and second to adjourn the next regular schedule. Board of Health meeting on September 27th, 2000. All those in favor, please say aye.
Aye.
Any opposed?
It was mine.